Okay, so it looks like it's working now. Well, hello, it's Dmitry again, and this will be our stream on the renal section for the Step 1 textbook, or I should say first aid for the Step 1 test or exam, the renal section. Now, the thing with this is that this is going to be a longer video because the renal section, as you can imagine, is not as short or as brief as the pocket physiology sections. And so just keep that in mind. You might want to maybe take a break here and there for this kind of thing. Okay, I just want to make sure that I'm setting everything up. And the other thing too is that I am reading from the latest edition of the Step 1 textbook. The first aid textbook I'm reading from whatever one was published, I think in 2025 or 2026. And the one that I have as a PDF is actually from, I think, 2021 or something like that. It is from an earlier year. It is a lot of overlap, as you can imagine, but it's not identical. So I'll be pulling from my textbook that I have in person, and I'll just refer to what page I'm looking at here as well. So from that, let me continue, and let me just check something quickly. Okay, good. That's running well. And I'm just going to go copy this. Give me a moment. There we go. Okay. So with that out of the way, I'm going to go proceed forth with the chapter at hand. So, high yield systems, renal. So it says here, it just says 3 quotes, and the 3 quotes are actually, I think they're similar. I think I have one from my book. I have Diane Lane, Hunter Madsen, Aldous Huxley. I think that's the only one that stuck around as the Madsen and Huxley one. So they changed out Rodney Dangerfield. Okay. Apparently, Rodney Dangerfield has been canceled, apparently. I guess they switched him out with somebody else. Well, let's see. But I know all about love already. I know precious little still about kidneys. Aldous Huxley is interesting. He wrote some interesting stuff, but fun fact, he's actually the grandson of Thomas Huxley, Professor, or I guess Dr. Thomas Huxley, who was a student of Darwin, which is, small world, I guess, or small England, I suppose. What else do I have? This too shall pass, just like a kidney stone. Hunter Madsen. I actually don't understand why they put these quotes in the front. It just seems kind of goofy to me, the whole thing. Anyways. Let's just read this part. Being able to understand and apply renal physiology will be critical for the exam. Important topics include electrolyte disorders, acid-base derangements, glomerular disorders, including histopathology, acute and chronic kidney disease, urine casts, diuretics, ACE inhibitors, and AT2 receptor blockers. Renal anomalies associated with various congenital defects are also high-yield associations to think about when evaluating pediatric vignettes. Good to know. And, again, there's not a perfect one-to-one between these 2 books because they are different editions. However, I will show you the pictures or the associated diagrams a lot of the time because those will be very similar to one another. Just FYI. So that's, for example, this diagram that I have here is the same diagram. Okay, renal embryology, kidney embryology. Pronephros, week 4 of development, then degenerates. Mesonephros, week 4 of development, functions as an interim kidney for first trimester in both sexes. Mesonephric ducts persist in the male genital system as Wolffian duct, forming ductus deferens and epididymis. Mesonephric ducts degenerate in females. Metanephros, permanent, First appears in week 5 of development. Nephrogenesis is normally completed by week 36 of gestation. Ureteric bud, metanephric diverticulum, fully canalized by week 10 of development, derived from mesonephric duct to form ureters, pelvises, calyces, and collecting ducts. Metanephric mesenchyme, that is to say, metanephric blastema, ureteric bud interacts with the tissue to induce differentiation and formation of glomerulus through distal convoluted tubule, DCT. Aberrant interaction between these two tissues may result in several congenital malformations of the kidney, that is to say, renal agenesis, multicystic dysplasia of the kidney. Ureter-pelvic junction, last part of the ureter to canalize. If it doesn't fully canalize, it causes a congenital obstruction, as you can imagine. Can be unilateral or bilateral. Most common pathologic cause of prenatal hydronephrosis, detected by prenatal ultrasound. Potter sequence, and let me just see if I have that available to me here. Yes, it has it right here. I'll just refer to this right here. Potter sequence. Oh, they had a diagram back in the day and they took it out. What's going on? So Potter sequence. Oligohydramnios, compression of the developing fetus, limb deformities like club feet, facial anomalies, that is to say, low set ears, and retrognathia, flattened nose, compression of the chest and lack of amniotic fluid aspiration to fetal lungs, pulmonary hypoplasia, cause of death, caused by chronic placental insufficiency or reduced fetal urine output, including ARPKD, obstructive uropathy, that is to say, posterior urethral valves, bilateral renal agenesis, preterm premature rupture of membranes, maternal ACE inhibitor use. Does not sound particularly fun to me. Now, it has this little thing right here on the side that says, oh, babies who can't pee in utero develop Potter sequence. Potter sequence associated with pulmonary hypoplasia, oligohydramnios, trigger, twisted face, twisted skin, extremity defects, renal failure in utero. Pretty serious stuff. Now, I'll go to the next section now. Again, this is all very similar. So, horseshoe kidney. As you can imagine, the kidneys have not radically changed in the last few years, so the material on it's going to be relatively similar. Horseshoe kidney. So you can see the horseshoe kidney there, there's a horseshoe kidney there, and you can see the renal artery, the renal vein, the ureter, the inferior mesenteric artery, and that was funnily enough, I was working on a quiz recently, and I'm thinking like, well, they're asking you like, hey, what's the structure that prevents the ascension of the kidneys if there's a horseshoe kidney? I'm like, is it the inferior mesenteric artery? Is it the superior mesenteric artery? It is the IMA. That is the thing that's preventing it from ascending. So just keep that in mind. If they ever have a test question on that, because that'll probably be, or something like that could be on something like step 1, Comlex, whatever. Inferior poles of both kidneys fuse abnormally. As they ascend from the pelvis during fetal development, horseshoe kidneys get trapped under the inferior mesenteric artery and remain low in the abdomen. Kidneys can function normally, but associated with hydronephrosis. Let me see where did I get caught up on? Okay, as they ascend, they get trapped to function normally, but associated with hydronephrosis, that is to say, ureteropelvic junction obstruction, renal stones, infection, increased risk of renal cancer. Higher incidence is chromosomal aneuploidy. For example, Turner syndrome, trisomies 13, 18, and 21. Now let's get into the congenital solitary functioning kidney. Condition of being born with only one functioning kidney, majority asymptomatic with compensatory hypertrophy of contralateral kidney, but anomalies in contralateral kidney are common. Often diagnosed prenatally via ultrasound bilateral agenesis or dysplasia leading to Potter sequence. And so you can have a Potter sequence associated with that in the case of congenital solitary functioning kidney. Unilateral renal agenesis. Ureteric bud fails to develop and induce differentiation of metanephric mesenchyme. Complete absence of kidney and ureter. Multicystic dysplastic kidney. Ureteric bud develops but fails to induce differentiation of metanephric mesenchyme, that is to say, leading to a non-functional kidney consisting of cyst and connective tissue. Non-genetic inheritance, though tends to run in families usually unilateral. I'm not quite sure. They're saying it's not genetic, but it's inherited. It's like, okay, well, what's the alternative mechanism that they're proposing for its inheritance? I'm not quite sure. Duplex collecting system. Bifurcation of ureteric bud before it enters the metanephric blastema creates a Y-shaped bifid ureter. Duplex collecting system can alternatively occur through two ureteric buds reaching and interacting with metanephric blastema. Strongly associated with vesicoureteral reflux and or ureteral obstruction. Increased risk for UTIs, frequently presents with hydronephrosis. Here we go. Posterior urethral valves. Membrane remnant in posterior prostatic urethra in males. Its persistence can lead to urethral obstruction. Diagnosed prenatally by bilateral hydronephrosis and dilated or thick-walled bladder on ultrasound. Severe obstruction in fetus associated with oligohydramnios. Most common cause of bladder outlet obstruction in male infants. So there's a little bit more information in this book than I have in here. And well, actually, no, it's pretty similar. Just that there's a diagram that I have available to me, so I can just describe it for you a little bit. It just shows you the kidney, the ureter, the bladder, the urethra in a normal person. Okay, seems pretty reasonable. But in this issue here, you see hydronephrosis. Okay, it's kind of this dilated kidney and irregularly shaped. You have this hydroureter, all this fluid in the ureter. Urinary reflux is going back up. And you have this, what's going on? A distended bladder, there's a hypertrophied wall, and there's the urethra obstructed by posterior urethral membrane. So basically what's going on is that, as far as I can tell, there's a obstruction, right, in the urethral valves. It can't let urine escape properly, at least not to the way that it should, or the rate that it should. As a consequence, there's a buildup of urine in the bladder and a kind of like a buildup going upward into the system all the way back to the kidney, leading to hydronephrosis. And so that's, you can imagine, is less than ideal. Anyway, we'll go to the next page. Vesicoureteral reflux. Retrograde flow of urine from bladder towards the upper urinary tract can be primary due to abnormal insufficient insertion of ureter within the vesicular wall, uretrovesical junction UVJ, or secondary due to abnormally high bladder pressure resulting in retrograde flow via the UVJ, increased risk for recurrent UTIs. Okay. And is that something that they added in? Yeah, kind of. It's kind of a related thing we were talking about before. Now, renal anatomy. It says here, renal blood flow. Left renal vein receives two additional veins, the left suprarenal and the left gonadal veins. Renal medulla receives significantly less flow than the renal cortex. This makes the medulla very sensitive to hypoxia and vulnerable to ischemic damage, that is to say, ATN. Left kidney is the most commonly taken during living donor transplantation because it has a longer renal vein. Rule of elves. Okay. So you want to take out the left kidney because there's a longer vein associated with it. Okay, fair enough. It has to do the crossover thing. If you're familiar with the anatomy of the renal system, yeah, it has a vein that has to cross over the aorta and the vessels in the down the center. Sorry, it's going across the aorta, unlike the vessels of the right kidney. So it's a little bit different in this situation. Now, it just shows the diagram. As you can see, there's an analogous diagram that you see here as well in this textbook. It's not exactly the same, but it is similar. And it's just showing, like the arcuate vein, interlobular arbor vein, renal vein, etc. Renal artery, segmental artery. Yeah, so the order is obviously like renal artery to segmental artery to interlobar artery to arcuate artery to interlobular artery. Then it becomes, you go to the Glomerulus, you have the afferent arteriole, glomerulus, efferent arteriole, peritubular capillaries, and eventually go into the interlobular vein, and into the arcuate vein, and into the interlobar vein, and then back to the renal vein. And so basically, the venous system of the kidney is basically just an inversion of order of the arterial system. It's reverse order, essentially. Just bear that in mind. And here's another diagram depicting the glomerulus, afferent arteriole, going through the glomerulus, eventually to the efferent arteriole. And of course, from efferent arteriole goes to the peritubular capillaries. And you can see the macular dens and everything like that, the JGA cells. That's where renin's being released, stuff like that. And you have a little bit of a diagram here as well. This little, we're showing Bowman's capsule like an actual image of it, I suppose. Okay. Course of ureters. And I'm also noticing, and this is a trend with these Step 1 textbooks, by the way, the first 8 Step 1 textbooks, is that they just get longer and longer as time progresses. Because I already see right here that this section on course of ureters is already a section that you don't see until, page 599 in my textbook, but it says page 550. Obviously, it's just like it's getting there's more stuff being added into the renal section for this textbook than it was in, I think, 2021. I could be mistaken. No, 2017. Oh wow. Correction, 2017. So they're just adding in more and more stuff. How wonderful. Course of ureters. Course of ureter, A, arises from renal pelvis, travels through the gonadal arteries, over common iliac artery, under the uterine artery vas deferens, retroperitoneal. Gynecologic procedures, that is to say, ligation of uterine or ovarian vessels, may damage ureter, ureteral obstruction or leak. Bladder contraction compresses the intramural ureter, preventing urine reflux. 3 common points of ureteral obstruction: uretopelvic junction, pelvic inlet, and uretovesical junction. Water, ureters, flows over the iliacs and under the bridge, uterine artery or vas deferens. So let me read that again. The ureters flow over the iliacs and under the uterine artery or vas deferens. So the ureters are over iliacs, but they're under the vas deferens and under the uterine artery. Water flows under the bridge. That is a thing they harp on a lot in anatomy class, where they're like, you have to know which ones are above and which ones are below. Just be aware of that. Renal physiology. Fluid compartments. So you can see, let me see if I can bring it down to you right here. Yeah, it's a little bit of a different graph, but it's sort of the same idea. So total body mass, 50 to 60%, 55 to 60% is total body of water. Okay. 1/3 of that water is extracellular fluid, and 2/3 of that is intracellular fluid. Now, of that extracellular fluid, 75% of it is interstitial fluid, while 25% of it's plasma, it's like stuff in the blood, Now, of those 2/3 that are intracellular fluid, 10% is RBC volume. That's interesting. I didn't know that one. That's a fun fact. And then the other 40 to 45% of non-water mass in the body, it doesn't really give any further description. But it's just trying to communicate here that the blood contains both plasma, but it also contains intracellular fluid in the actual RBCs themselves. As an FYI, I suppose. And so the actual blood volume, well, the plasma plus RBC volume is about 6 liters. Okay, cool. And normal hematocrit is about 37% to 50%. Hyken, high potassium intracellularly. So you have high potassium intracellularly. 60, 40, 20 rule. Percent of body weight for average person. 60% water, 40% intracellular, mainly composed of potassium, magnesium, organic phosphates, that's to say ATP, and 20% is extracellular fluid, mainly composed of sodium, chloride, bicarb, and albumin. So in intracellular, you have a lot of potassium, magnesium, and ATP. Extracellular, you have a lot of sodium, chloride, and bicarb and albumin, which makes sense. Plasma volume can be measured by radiolabeling albumin. Extracellular volume can be measured by imulin or mannitol. Serum osmolality, 275 to 295 milliosmoles per kilogram of water. Plasma volume is TBV times 1 minus hematocrit. I think that is. Glomerular filtration. Okay. Glomerular filtration barrier. Responsible for filtration of plasma according to the size and charge selectivity. Composed of fenestrated capillary endothelium, glomerular basement membrane, GBM, with type 4 collagen chains and heparin sulfate. Visceral epithelial layers consisting of podocyte foot processes, FPs. Charge barrier, glomerular filtration barrier, contains a negative charge glycoproteins that prevent entry of negative charge molecules, that is to say, albumin. Size barrier, fenestrated capillary endothelium, prevents entry of greater than 100 nanometer molecules / blood cells. Slit diaphragm prevents entry of molecules greater than 40 to 50 nanometers. And so I'm going to go back into that a little bit. Might repeat a little bit, but one of the things I want to point out initially is about that charge barrier. Okay, let me see something. Molecules / blood cells. Slit diaphragm prevents entry of molecules greater than 40 to 50 nanometers. Okay. And podocyte foot processes interpose of GBM, both charges and size barrier. So one of the things I wanted to say about that is that the actual barriers are very important for preventing albumin. So, for example, the charge barrier is used for preventing albumin from getting through. That is extremely important because albumin needs to be in the blood to maintain the colloid osmotic pressure. If you do not have that, you will have edema as a consequence of that. So when you have some of these disorders of the kidney, you can have loss of albumin loss, and as a consequence, you have to have things like edema because you're losing all that colloid osmotic pressure. You know, it's not like an arbitrary thing. Oh, the body just has sodium here and potassium here and chloride here and ATP here and albumin here just for arbitrary reasons, or like it's a spandrel or something. No, you know, typically what's going on is that you actually have a reason for things happening, and if it's no longer there, it can lead to serious consequences in ways that you might not understand initially. So moving on. And let me just check something quickly. Okay. Here we go. Renal clearance. So now it's back to the same page, I guess. Renal clearance. It says here, Cx equals Ux times V, all divided by P, equals volume of plasma from which the substance is completely cleared in the urine per unit time. If Cx is less than GFR, net tubular reabsorption and or not freely filtered. If Cx is greater than GFR, net tubular secretion of X. Okay. If Cx equals GFR, no net secretion or reabsorption. Cx equals clearance of X, milliliters over minutes. Ux equals urine concentration of X, that is to say, milligrams over milliliters. Px equals plasma concentration of X, that is to say, milligrams over milliliters, okay. And V equals urine outflow rate, ml over minutes, okay. So basically what they're saying is that the clearance of something is equivalent to the urine concentration of that thing times the urine flow rate, all divided by the plasma concentration of that thing. To put it in a more direct sense. Now, glomerular filtration rate. Inulin clearance can be used to calculate GFR because it is freely filtered and is neither reabsorbed nor secreted. C of inulin, clearance of inulin is equivalent to GFR equals the urine concentration of inulin times the urine flow rate divided by the plasma concentration of inulin, which equals KF, and then like these sorts of brackets here, and then parentheses, PGC minus PBS, all in parentheses again, minus pi GC minus pi BS. Okay. PGC equals glomerular capillary hydrostatic pressure. PBS equals Bowman space hydrostatic pressure. pi GC equals glomerular capillary oncotic pressure, pi BS equals Bowman space oncotic pressure, pi BS normally equals 0, Kf equals filtration coefficient. Normal GFR is equivalent to about 100 milliliters per minute. Creatinine clearance is an approximate measure of GFR. Slightly overestimates GFR because creatinine is moderately secreted by proximal renal tubules. And you can just see right here on the diagram with the plasma creatinine levels and the GFR. When you have higher GFR, unsurprisingly, you're going to have lower creatinine levels in the plasma. There we go. Effective, let me read this, renal blood flow autoregulation. Autoregulatory mechanisms help maintain a constant RBF and GFR to protect the kidneys from rapid fluctuations in renal perfusion pressure that could cause renal injury, leading to reduced glomerular filtration. Mechanisms: myogenic, increased arterial pressure, stretch of afferent arteriole, mechanical activation of vascular smooth muscle, vasoconstriction of afferent arteriole, causing a decrease in RBF. Renal blood flow, right? Tubuloglomerular, increase in sodium chloride of the filtrate sensed by macula densa cells, causes a paracrine-driven vasoconstriction of the afferent arteriole, which decreases renal blood flow. It can also have the opposite effect on renal blood flow if the salt levels are, NaCl is low, obviously. Effective renal plasma flow. Effective renal plasma flow, ERPF, can be estimated using the para-aminohippuric acid PAH clearance. Between filtration and secretion, there's nearly complete excretion of all PAH that enters the kidney. ERPF equals UPAH times V divided by P PAH equals C PAH. Renal blood flow, RBF equals RPF divided by 1 minus HET. Usually 20 to 25% of cardiac output. ERPF underestimates true renal plasma flow, RPF slightly. And they don't show a diagram here, which I can see in my own textbook, but you will see an afferent arteriole. We can see the PAH is, you see, go through, goes to the afferent arteriole, travels through, eventually goes to the efferent arteriole, and then it goes back down, and so forth. And you can see that by the time you're in the kind of Bowman space, 20% filtered occurs throughout PT, and then it goes, by the time you get to after you're kind of going through the efferent portion, it says here that 80% has been secreted, and that's referring to, I think, the collecting duct at that point. No, actually, that's not quite true. But eventually it says here that 100% is excreted, is the point. Although it's not necessarily happening at all at one location, per se. Oh, they have it right here. Looks like, well, that's not the same thing, but it is similar, certainly. So we'll continue with that. Filtration. Filtration fraction FF equals GFR divided by RPF. Normal FF is equivalent to filtration fraction is about 20%. Filtered load, mg over minutes, equals GFR, again, ml over minutes, times plasma concentration, mg over ml. GFR can be estimated with creatinine clearance. Prostaglandins dilate afferent arteriole, PDA. Angiotensin II constricts efferent arteriole, ACE. RPF is best estimated with PAH clearance. NSAIDs and ACE inhibitors should not be given together. Constriction of afferent and efferent arterioles. So that's just a reference point that if you're taking, let's say, for example, if you're taking an ACE inhibitor, do not take NSAIDs at the same time, which is hard to do because, people take NSAIDs all the time, like, whatever, right? So just keep that in mind if you're taking an ACE inhibitor for blood pressure, for example. Anyway. It says here NSAIDs are preventing prostaglandins preferentially dilate afferent arteriole, increase RPF, increase GFR, so no delta FF change in filtration fraction. NSAIDs are inhibiting that process, of course. The ACE inhibitors are working here. It says angiotensin II preferentially constricts afferent arteriole, causing a decrease in RPF, an increase in GFR, and so therefore an increase in filtration fraction. ACE inhibitors are preventing that from happening. And this shows the changes in glomerular dynamics. So let's say, for example, let's say my afferent arteriole is constricted. It's going to decrease GFR, obviously. It's going to decrease the RPF. Okay. Renal plasma flow is going to decrease. And there's also going to be no change necessarily in filtration fraction. Now, let's say, for example, I have an efferent arterial constriction. I have an increase in GFR, of course. I have a decrease in RPF and renal plasma flow, again, actually. And I'm going to have an increase in filtration fraction. That's interesting. Now, let's say I have an increase in plasma protein concentration. I have an increase in plasma protein. So I'm going to have a decrease in GFR. Okay. I'm not going to change the renal plasma flow at all. Okay. But I'm going to have a decrease in filtration fraction. That's interesting. Let's say, for example, I'm decreasing plasma protein concentration. Well, I'll assume the opposite is going to happen. I'm going to increase GFR. I'm going to not change RPF. I'm going to increase filtration fraction. Now, let's say, for example, there's constriction of the ureter. Okay, what's going to happen then? Decreasing GFR. Okay, fair enough. RPF is not going to change. That's interesting. And the filtration fraction is also going to decrease. Okay. Let's say I'm dehydrated, for example. What's going to happen? My GFR is going to go down. Okay. The RPF, the renal plasma flow, is going to radically go down. Okay. And the filtration flow is going to increase. Notably, for patients undergoing nephrectomy, there is a proportionate decline in renal function, decrease in nephron number, leading to a decrease in remaining kidney renal function to 50% of pre-nephrectomy levels, pre-nephrectomy value, until long-term compensations like hypertrophy develop. And that goes back into the whole fact that the body is trying to compensate for everything that goes wrong to the best that it can, which unfortunately isn't always enough. Sometimes it is, sometimes it isn't. That's crazy. Okay. This is a long section for reference compared to what I was looking at before. So let me just check. Yeah, it is exactly what you expected it to be. Oh, okay, yeah. I could do that. I could say, for example, I want to divvy it up into different sections, because there is a pharmacology section, there is a pathology section, and there is a whatever section, you could say. But we're just going to power through this as much as we can. Calculation of reabsorption and secretion rate. Filtered load equals GFR times px. Now, let me just confirm I'm making sure what I'm talking about when I say that. Plasma concentration of X. So filtered load equals GFR times plasma concentration of X. Excretion rate is equivalent to the urine flow rate times the urine concentration of X. And that's all right here. Reabsorption rate is equals filtered minus excreted. Fair enough. Yeah, that makes sense. Secretion rate equals excreted minus filtered. True. So secretion, that's an important thing to distinguish between. Secretion and excretion are not the same thing in the context of the kidneys. Secretion is like the net effect. Excretion is like the total kind of effect. So let's say, for example, I will excrete 10 units of something, but I reabsorb, I filter out 2 units of something. That means my secretion rate is the net effect is only 8. So that's kind of how that works. Just bear that in mind if you have a question on that. FeNA equals fractional excretion of sodium. Oh, FeNA. Fractional excretion of sodium. Okay, fair enough. So fractional excretion of sodium is equivalent to sodium excreted divided by sodium filtered, which equals V times U Na divided by GFR times P Na, which equals PCR times U Na divided by UCR times P Na, where GFR equals UCR times V all divided by PCR. Cool. Glucose clearance. Glucose at a normal plasma level, range 60 to 120 mg over deciliters, is completely, or is that deciliters? DL, whatever, is completely reabsorbed in proximal convoluted tubule PCT by sodium over glucose co-transport. Well, no, sodium glucose co-transport, sorry, yeah. In adults, at plasma glucose of 200 mg DL, glucosuria begins threshold. At a rate of 375 milligrams over minutes, all transporters are fully saturated, TM. Normal pregnancy is associated with increased GFR with increased infiltration of all substances, including glucose. The glucose threshold occurs at lower plasma glucose concentrations, glucosuria at normal plasma glucose levels. Sodium glucose cotransporter 2, SGLT2, inhibitors like Flozin drugs lead to glucosuria at plasma concentrations less than 200 mg/dL. Glucosuria is an important clinical clue due to diabetes mellitus. Splay phenomenon, TM for glucose is reached gradually rather than sharply due to the heterogeneity of nephrons, that is to say, different TM points represented by the portion of the titration curve between threshold and TM. And they just show a graph right there in the book as well, just showing the filtered versus the excreted versus the reabsorbed, the threshold display, that kind of thing. I'm wondering where does the physiology section? The physiology section is always the largest section for this textbook. It's going to go into path eventually. Here we go. Path starts on 612 for me, and I'm 603 right now. Nephron transport physiology. And so they just show a couple different diagrams here. I actually like this textbook version that I have in the PDF a little bit better in a certain sense, because it actually shows you the original thing that you want to be referring to. Like, it gives you a reference point. Now, my book has kind of the same graphs. It shows, oh, here's the early PCT, the early DCT. It shows let me show it down here, thick ascending loop of Henle, the collecting tubule, that kind of thing. But it's not really showing you, in my textbook, this central figure right here, showing you where those things are actually located. And so that's actually extremely useful in my humble opinion. Anyway, early PCT, let me show the whole thing right here for you. Early PCT contains brush border, reabsorbs all glucose, so early proximal convoluted tubule, which is right there, right after we get from Bauman's capsule, contains brush border, reabsorbs all glucose and amino acids, and most bicarb and sodium chloride, phosphate, potassium, water, and uric acid. Isotonic absorption generates and secretes ammonia, which enables the kidneys to excrete via secretions more hydrogen ions. PTH inhibits sodium phosphate cotransport and increase in phosphate excretion. AT2 stimulates sodium hydrogen exchange, increasing the sodium, water, and bicarb reabsorption, permitting contraction alkalosis. 65 to 80% sodium and water is reabsorbed. Okay. So let's go to the next one. Let's go to the thin descending loop of Henle right here. So thin descending loop of Henle. I want to go in order, okay? Thin descending loop of Henle, passively reabsorbed water via medullary hypertonicity, impermeable to sodium, concentrating segment, makes urine hypertonic. Cool. And I don't even think I have that in my text. No, I do have it right here. Okay. And then we're going to go to the next portion, which is going to be the thick ascending loop of Henle. So the thick ascending loop of Henle reabsorbs sodium, potassium, and chlorine indirectly, induces paracellular reabsorption of magnesium and calcium through positive lumen potential generates by potassium back leak, impermeable to water, makes urine less concentrated as it descends. 10 to 20% of sodium reabsorbed. Okay. Early distal convoluted tubule. And you can see where that's located now. Reabsorbs sodium chloride, sodium and chloride, impermeable to water, makes urine fully dilute, hypotonic. PTH, parathyroid hormone, increases calcium and sodium exchange, increasing the calcium reabsorption. 5 to 10% of sodium is reabsorbed. Okay, and then we have this final section right here called the collecting tubule. It's that last portion of the nephron. I'm not sure if we're talking about from an anatomical perspective, do we consider that to be the end point of the nephron, or do we consider that to be the portion right after the nephron? I'm not exactly keen on that, but as far as I'm concerned, it is part of nephron, to my knowledge, right? So this is a lot larger, and I'll just read it for you right now. Collecting tubule reabsorbs sodium in exchange for secreting potassium and hydrogen regulated by aldosterone. Aldosterone acts on mineralocorticoid receptor, mRNA, acts on mineralocorticoid receptor, leading to mRNA, leading to protein synthesis, in principal cells, increases apical potassium conductance, increases sodium potassium pump, increases epithelial sodium channel. Sodium increases, where was I? Okay. In principal cells, increases apical potassium conductance, increases sodium potassium pump, increases epithelial sodium channel, ENaC activity, leading to lumen negativity, leading to potassium secretion. In alpha intercalated cells, lumen negativity leads to increase in hydrogen ATPase activity, increasing the hydrogen ion secretion, increasing the bicarbonate chlorine exchanger activity. ADH acts at the V2 receptor, insertion of aquaporin H2O channels on apical side. 3 to 5% of sodium is reabsorbed. Urea reabsorption, medullary, not cortical duct only. Okay, nice to know. And I would recommend definitely making sure that you understand everything about that, because that is the key ticket item. Give me a moment. There we go. There we go. There we go. So yeah, that's basically the key thing, is understanding what's going on in each portion of the nephron. I think it's one of the biggest issues when we talk about the kidneys and how they work. And along with that, knowing about, what drugs work where and what happens, what are the side effects, because that'll help you understand what's going on. Very, very big item. Renal tubular defects. Order Fanconi's bagels. This is my textbook. I guess that's an update. Renal tubular defects. Order Fanconi's bagels. Okay. So Fanconi syndrome. This is going to talk about defects, effects, causes, and notes. So what are the defects of Fanconi syndrome? Generalized reabsorption defect in the proximal convoluted tubule, leading to an increase in excretion of amino acids, glucose, bicarb, and phosphate, and all substances reabsorbed by the PCT. It causes metabolic acidosis, proximal RTA, hypophosphatemia, and hypokalemia. It's caused by hereditary defects like Wilson's disease, tyrosinemia, glycogen storage disease, ischemia, multiple myeloma, drugs, that is to say, ifosfamide, cisplatin, tenofovir, lead poisoning. And this additional notes, growth restriction and rickets osteopenia common due to hypophosphatemia, volume depletion also common. Now, Bartter syndrome. Reabsorption defect in thick ascending loop of Henle affects the sodium, potassium, and chloride transporter. Causes metabolic alkalosis, hypochloremia, hypokalemia, hypercalciuria, autosomal recessive, presents similarly to chronic loop diuretic use. Okay. Gittleman syndrome. Reabsorption and defect in the sodium chloride and DCT, distal convoluted tubule. Oh, cool. Mine has a little of a graph that shows, Fanconi syndrome, Bartter syndrome, Gittleman syndrome, Little syndrome, same and same. Yours doesn't have that, unfortunately, but it just gives you a good perspective. You could just, if you have one of these diagrams, you print one out, maybe you draw one out, just label where these things are located, just for a reference point. Gittleman syndrome, reabsorption defect in the sodium chloride in DCT, metabolic alkalosis, hypochloremia, hypomagnesemia, hypokalemia, autosomal recessive, presents similarly to chronic thiazide diuretic use, less severe than Bartter syndrome. Little syndrome is a gain-of-function mutation leading to a decrease in sodium channel degradation, increasing sodium reabsorption in collecting tubules. Metabolic alkalosis, hypokalemia, hypertension, decrease in serum aldosterone. Autosomal dominant, and it presents with similar to hyperaldosteronism, but aldosterone is nearly undetectable. The treatment would be amiloride. Okay, gotcha. Syndrome, so same. Syndrome of apparent mineralocorticoid excess. So tell us about it. Cortisol activates mineralocorticoid receptors, 11-beta HSD, and it converts, let me go pull this up for you right here, and it converts cortisol to cortisone, inactive on these receptors. Hereditary 11-beta HSD deficiency leads to an increase in cortisol, leading to an increase in mineralocorticoid receptor activity, causing metabolic alkalosis, hypokalemia, hypertension, decrease in serum aldosterone levels. Cortisol tries to be the same as aldosterone. Autosomal recessive can acquire disorder from glycyrrhetinic acid present in licorice, which blocks activity of 11-beta hydroxysteroid dehydrogenase. The treatment is potassium-sparing diuretics, decreasing the mineralocorticoid effects, or corticosteroids, exogenous corticosteroid, decreasing endogenous cortisol production, leading to a decrease in mineralocorticoid receptor activation. Okay, and now we're on the next section. Features of renal disorders. Condition SIADH causes a no effect or an increase in blood pressure. It has no effect or possibly decreases plasma renin. It has no effect or possibly decreases aldosterone. It has no effect on serum magnesium. It has no effect on urine calcium. Bartter syndrome has no effect on blood pressure. It increases plasma renin. It increases aldosterone. It has no effect on serum magnesium. It does increase the urine calcium levels. Gittleman syndrome increases plasma renin, increases aldosterone, decreases serum magnesium, and it decreases urine. Important to note. Do I have this diagram in this textbook at all? I feel like it would be a pretty reasonable thing to have. They don't have that. Wow, that's crazy. Well, I guess it pays to buy the most recent book, I guess, maybe, unless it's not on the exam itself, so in which case it wouldn't really matter. But anyway, renin-secreting tumor that'll increase blood pressure, increase plasma renin, increase aldosterone, and not have any real impact on magnesium or urine calcium. And one of the things I want to say probably is that if you have an increase in aldosterone and plasma renin, you're probably going to have an increase. I would say this. I would say typically if you had an increase in aldosterone, plasma renin, you would have an increase in blood pressure. But apparently a lot of these syndromes do not necessarily. They might not necessarily have a complete overlap per se, because there's a lot of other things going on, I suppose. Now, primary hyperaldosteronism will lead to an increase in blood pressure, and a decrease in renin, and an increase in aldosterone, obviously. Little syndrome has a decrease of apparent mineralocorticoid excess, has a decrease in aldosterone, okay, an increase in, or a decrease in renin as well, but an increase in blood pressure. And I'm just saying the red arrows are important differentiating factors. Again, that's not going to be in your textbook, it's just in mine. But you do have this little graph right here. It says relative concentrations along proximal convoluted tubules. I do have this right here. I'll go into it. It says here TF over P greater than 1 when solute is reabsorbed less quickly than water or when solute is secreted. TF over P equals 1 when solute and water are reabsorbed at the same rate. And then TF over P is less than 1 when solute is reabsorbed more quickly than water. tubular inulin in concentration, but not amount, along the PT as a result of water reabsorption. Chlorine reabsorption occurs at a lower rate than sodium in early PCT and then matches the rate of sodium reabsorption more distally. Thus, its relative concentration increases before it plateaus. Oh, great. The diagram is a little bit different this year, apparently. Or at some point it was changed. I might take a little bit of a break after physiology is complete, but that's not going to be until another handful of pages, I guess I could say. So, renin, angiotensin, aldosterone system. So you can see this a similar, or let's say an analogous graph on your situation. What I'm seeing, the DCT, the macula densa, the JGA cells. The JGA cells produce renin, which converts angiotensinogen, which comes from the liver, into angiotensin 1, and then angiotensin 1, under the influence of ACE, converts angiotensin 1 into angiotensin 2. Angiotensin 2 has a number of different effects, as you can imagine, including on the angiotensin 2 receptor type 1s, on, I think those are blood vessels leading to vasoconstriction and increase in BP. It goes back into the glomerular or nephron system, and it goes to preferentially constricts the efferent arteriole, leading to an increase in filtration fraction, preserves GFR when RBF is low. And it says here it goes to the kidney, or maybe it looks like the kidney, increasing sodium hydrogen activity, PCT cell. Sodium, bicarb, and water reabsorption permits a contraction of alkalosis. Okay. It goes to the adrenal gland, causes aldosterone secretion, leading to alpha intercalated cells to have hydrogen secretion, increase in hydrogen ion ATPase activity, okay? And also goes to the principal cell, leading to sodium reabsorption, potassium secretion, increase in potassium conductance, sodium potassium ATPase, and ENaC activity, as well as water reabsorption via aquaporins. That's correct. That's true, definitely. That's a major effect that they harp on when we talk about ACE inhibitors. They're always focused about the water reabsorption. Or I might be thinking about, sorry, no, I'm confusing two different things. Now, that is true. That is true. It is part of the system, how this stuff works. But I'm thinking more about the about ADH in this case. But angiotensin 2 does increase, does go to the hypothalamus, causing thirst, and it goes to the posterior pituitary to release ADH. And then ADH is going to go to the principal cells or renal cells, and it's going to cause water reabsorption via aquaporins. And that's something that we associate with that 100%, is we associate ADH, or even the things that are supposed to imitate ADH, like desmopressin, for example, is supposed to be analogous to vasopressin. These things will help encourage water reabsorption via aquaporins. Now let's go down here. Renin. Renin is secreted by JG cells in response to a decrease in renal perfusion detected in afferent arteriole, increasing renal sympathetic discharge, beta-1 effect, and a decrease in sodium chloride delivery to macula densa cells. ACE catalyzes conversion of angiotensin 1 to angiotensin 2, located in many tissues, but conversion occurs most extensively in the lung, produces by vascular endothelial cell in the lung. AT2 helps maintain blood volume and blood pressure, affects baroreceptor function, limits reflex bradycardia, which would normally accompany its pressor effects. ANP and BNP, these are like atrionatriuretic peptide and brain natriuretic peptide. Now, BNP is released in the ventricles, I believe, and then the atrionatriuretic peptide is released, of course, in the atria. They're released from atria, ANP, and ventricles, BNP. Wow, great. I'm so glad that they know what I'm talking about as much as I do, I guess. In response to increase in volume, we're on the same page, In response to increase in blood volume, relaxes vascular smooth muscle via the cyclic GMP, leading to an increase in GFR and a decrease in renin, leading to an angiotensin aldosterone inhibition, dilates afferent arteriole, and promotes natriuresis. Now, one of the things I want to say about that in particular is that the best way you can think about ANP and BNP is that it's kind of the opposite of aldosterone in terms of its actual effects, just for a reference, okay? ADH, or vasopressin, primarily regulates serum osmolality, also responds to low blood volume states, stimulates reabsorption of water in collecting ducts, also stimulates reabsorption of urea in medullary collecting ducts to maximize corticopapillary osmotic gradient. Okay, and that's ADH is talking about kind of vasopressin, and the analog to that would be things like desmopressin, which I think is called DDAVP. Now, aldosterone primarily regulates ECF volume and sodium content, increases release in hypovolemic states. Increased release of aldosterone in hypovolemic states. Okay, fair enough. Responds to hyperkalemia by potassium excretion. I'm going to take a little. Well, I have one more left before I get into the kidney endocrine paracrine function. So I'll just go over the JGA apparatus. JGA, the juxtaglomerular apparatus, consists of mesangial cells, JG cells, modified smooth muscles of the afferent arteriole and the macula densa, sodium chloride sensor located at the DCT. JG cells secrete renin in response to decreases in renal blood pressure and increase in sympathetic tone. Macula densa cells decrease sodium chloride delivery to DCT, increasing renin release, afferent arterial vasoconstriction, leading to increase in GFR. Communication between JG cells and macula densa occurs via gap junctions. Interesting. Now, the JGA prevents short-term changes in GFR through autoregulation and maintains GFR long-term through regulation of the renin-angiotensin-aldosterone system. Beta blockers decrease BP by decreasing cardiac output and inhibiting beta-1 receptors of the JGA, decreasing renin release. Now, I will say, however, though it's true that they do inhibit the cardiac output by messing with the renin release, it's overwhelmingly because of the cardio effects. And so when we think about beta-1, for example, beta-1 is considered cardioselective. So when you take atenolol, for example, they say, atenolol is a cardioselective beta blocker. And that's kind of true because beta-1 is very, very heavy in the heart, but it does technically also exist at this location as well, although not nearly as important by comparison. I'm going to take a little bit of a break and come back in maybe a minute or so. That's crazy. Okay. Well, I'm not exactly keeping track of time in that sense. Bear in mind that, this is a 35-page chapter or something like that. And there's a lot of ground to cover. So we're getting through it though. Kidney endocrine paracrine function. Erythropoietin. Erythropoietin released by the interstitial cells in peritubular capillary bed in response to hypoxia. Stimulates the RBC proliferation in bone marrow. Administered for anemia secondary to chronic disease. Adverse effects include an increase of risk for hypertension in some individuals. Okay. Calciferol, also called vitamin D, if you haven't heard of it before. PCT cells convert 25 hydroxy vitamin D3 to 125 hydroxy vitamin D. Is that dihydroxy? I don't really care. 125 OH 2 vitamin D3 calcitriol active form. So it's basically converting the vitamin D3 to vitamin D3 calcitriol active form. Increases calcium absorption in the small bowel. So it says here 25 hydroxy D3 becomes 125 dihydroxy D3 via 1 alpha hydroxylase, which is being promoted by the PTH, the parathyroid hormone. So that might be another kind of question I might ask you about. Is like, what is the XYZ thing? Where is it happening? That kind of thing. And you have to just know, well, this is happening at the PCT. And prostaglandins. Paracrine secretion vasodilates afferent arterioles to increase the renal blood flow. True. NSAIDs block renal protective prostaglandin synthesis, leading to a constriction of the afferent arteriole and a decrease in GFR. This may result in acute kidney injury in low renal blood flow states. Just be aware of that when you give a patient NSAIDs, that this might be a problem depending on what their kind of health circumstances are. And dopamine, secreted by the PT cells, promotes natriuresis at low doses, dilates intralobular arteries, afferent arterioles, leading to an increase in renal blood flow, little or no change in the GFR. At higher doses, it acts as a vasoconstrictor, so kind of a different effect, essentially. Usually dopamine is not necessarily problematic unless you're giving a lot of it for something like, let's say, for example, the patient is they're experiencing shock, and we say, oh, we want to do vasoconstriction, let's give them a lot of dopamine. That's when you want to be aware of what the effects are in the kidneys, for example. And so now we're on this portion right here, saying, oh, these are the hormones acting on the kidney. Okay. Well, this is a nice diagram. There's a lot of nice diagrams in this thing, and this is basically the same that I have in my own textbook. I think it is the same thing, almost identical, it looks like. Or it is identical, I think. Anyway, so let's talk about it. Angiotensin II. Angiotensin II is in the blue, and as you can see, it has effects on a lot of different parts of the actual nephron. It has effects on the efferent arteriole, on the proximal convoluted tubule, on the thick ascending loop of Henle. Sorry, the ascending limb of loop of Henle, the distal convoluted tubule. It has a lot of different effects. So that's angiotensin II, very important. Synthesized in response to a decrease in BP, causes efferent arterial constriction, leading to an increase in GFR and an increase in filtration fraction, but both compensatory sodium reabsorption in proximal and distal nephron. Net effect is preservation of renal function, increase in filtration fraction in low urine volume states, with simultaneous sodium reabsorption both proximal and distal to maintain circulating volume. Now, the parathyroid hormone secreted in response, and that's going to be affecting the proximal convoluted tubule and the distal convoluted tubule, as you can see here. Parathyroid hormone secreted in response to the decrease in plasma calcium concentrations, increase in plasma phosphate, or a decrease in plasma 125 dihydroxy D3, which is as we brought up before, is the calcitriol, which is the active form. Now, it causes an increase in calcium reabsorption, DCT, decrease in phosphate reabsorption, PCT, and an increase in calcitriol production. Increase in calcium and phosphate absorption from gut via vitamin D. Okay. That's parathyroid hormone. Cool. And then we have the distal convoluted tubule, and then we go over here. Let's look at aldosterone now. Aldosterone, which is going to be impacting it looks like it impacts really the collecting duct. Secreted in response to a decrease in blood volume, of course, by the AT2, and an increase in potassium. Causes the increase in sodium reabsorption, increases the potassium reabsorption. Oh, I'm sorry. That's crazy. AT2 just means angiotensin II. I'm like, what on earth could they be referring to that as a 2 in the name? It's like, well, there's one thing that's pretty obvious that has a 2 in it, angiotensin II. Anyway, so secreted in response to decrease in blood volume via angiotensin II and an increase in potassium. It causes sodium reabsorption, and it increases potassium secretion, and it increases hydrogen ion secretion as well. Now, ADH, vasopressin, is secreted in response to an increase in plasma osmolarity and a decrease in blood volume. It binds to the receptors on principal cells, causing an increase in number of aquaporins and water reabsorption, increase in reabsorption of urea in medullary collecting ducts to maximize corticopapillary osmotic gradient. Then we also have here the atrial natriuretic peptide, which is going to be impacting the collecting duct, sure, but also the afferent arteriole. And I would say Along with that, the ANP is going to resemble basically what the BNP does as well. But let's just look at the ANP. The ANP secreted in response to the increase in atrial pressure causes indirect afferent arterial dilation through inhibition of norepinephrine, causes an increase in GFR and an increase in sodium filtration, and no compensatory sodium reabsorption in distal nephron. Net effect would be sodium loss and volume loss. Again, that's like kind of the inversion of what aldosterone will do. Okay. But it also has an impact on the afferent arterial, just for reference, which is going to have interesting effect. It's going to increase GFR, or causes increase in GFR and sodium filtration. Yeah. Okay. Good. Okay, I see. Potassium shifts. Shifts in potassium into the cell. So the difference between my book and the book PDF presented here is that I actually have a diagram, it looks like, as opposed to this table right here that you're seeing. So that's interesting. But I'll explain what's going on here. So it shows shifts to potassium into cell. You have these reversible hydrogen potassium exchangers. Oh, yours is just like a table of drugs that you can use. So let's say shifts potassium into the cell causing hypokalemia and shifts potassium out of the cell causing hyperkalemia. So what causes hypokalemia for us? Hypoosmolarity, alkalosis, beta adrenergic agonist, sodium potassium ATPase, insulin, sodium potassium ATPase, and insulin shifts potassium in the cells. Of course, sure. And what are the ones that shift things out of the cell? Digitalis blocks sodium potassium ATPase, hypoosmolarity, lysis of cells, crushed injury, rhabdomyolysis, tumor lysis syndrome, acidosis, beta blockers, high blood sugar, insulin deficiency, and succinylcholine, increased risk in burn, muscle trauma, hyperkalemia, do labs, and the B is a beta. Okay. So I have some of that same stuff. It's just a little bit different. It's a diagram as opposed to whatever you're showing here. I think that was a little bit more straightforward in my honest opinion. So I'm looking at digoxin, beta blockers, hyperinsulinemia, block those sodium potassium things. Okay. Acidosis will encourage hydrogen to, looks like it's going to promote that right there. Succinylcholine promotes at the sodium potassium ATPase, I think, nicotinic ACH receptor. Okay. Cell lysis can have an impact, of course, which isn't, I don't think that mentions it. It says lysis of cells, crushed injury, rhabdomyolysis, tumor lysis syndrome. Okay. And then serum osmolality. The ones that cause shifts into the cells, the potassium is going to be alkalosis, of course, we brought up before, and beta agonists and insulin, of course. So let's go to electrolyte disturbances. So sodium, so electrolytes, low serum concentration, high serum concentration. Let's say I have low sodium. I have hyponatremia. Whatever guys would be, yeah, I mean, whatever. Your hyponatremic would not be a totally inaccurate way to phrase it, but yeah, you have low sodium. Nausea, malaise, stupor, coma, seizures. And you have high serum of sodium, you have hypernatremia, you have irritability, stupor, and coma. Well, isn't that fun? If it's too low or it's too high, it can cause a stupor or a coma. How fun is that? Now, potassium, U wave, if you have low potassium, you'll have U waves, flattened T waves on ECG, arrhythmias, muscle cramps, spasms, and weakness. If you have a high potassium, you have hyperkalemia, you will have wide QRSs and peaked T waves on ECG. Arrhythmias and muscle weakness. So the ECG thing is interesting, how it's impacted by the potassium levels. Let's say I have high calcium, I have hypercalcemia, or low calcium, hypocalcemia. Tetany, seizures, QT prolongation, twitching, like this is here, Schwastek sign, spasm, like Trousseau sign. Okay. And you have high calcium, of course, you get into things like stones, renal stones, bones, bones, and groans. Stones, renal, bones, pain, groans, abdominal pain, thrones, increase in urinary output frequency, psychiatric overtones, anxiety, altered mental status. So they say, stones, bones, groans, thrones, psychiatric overtones. Well, I think they're kind of stretching that a little bit in terms of the mnemonic there. Magnesium, let's say you have low magnesium, hypomagnesemia. Tetany, kind of like calcium. Tetany, torsade de pointe. How do you pronounce it? It's torsade. I would say torsades, but torsade de pointe. I can't speak French. Hypokalemia, hypocalcemia, when magnesium is lower than 1.0 milliequivalents per liter. Decreasing, if you have high magnesium, you'll have lower DTRs, lethargy, bradycardia. By the way, DTR in this case means deep tendon reflex, for reference, hypotension, cardiac arrest, hypocalcemia. Phosphate levels, if you have low phosphate, you'll have bone loss, osteomalacia, adults, and rickets in children. Pretty nasty stuff. And you have hyperphosphatemia, or high phosphate, you'll have renal stones. Again, it's kind of a calcium situation. Metastatic calcifications, and hypocalcemia. Interesting. So phosphate is very intimately connected to calcium levels and what's going on with calcium. Now you have a thing called features of renal disorders, and I think that's what I was reading out before. They must have moved the location, so just keep that in mind. You can read that there. I already went through it before. Okay, next page. Acid-base physiology. Metabolic acid-base disorders cause bicarb alterations. Respiratory acid-base disorders cause PCO2 alterations. So let's say I have metabolic acidosis. I have metabolic acidosis. This is not complicated in my opinion, but something you definitely need to know. So just bear that in mind. So let's say, for example, I have metabolic acidosis, right? I have low pH. Duh. I also have low CO2. Now, why would that be the case? Well, that's because you're having a compensation, basically. Now, you have low bicarb. That makes a lot of sense, right? Because that's the reason why you have the metabolic acidosis. So you have hyperventilation. That's the compensatory mechanism. Let's say you have metabolic alkalosis. So I have high pH, right? And I'll actually have high bicarb. That's the reason why. And then I'll have this compensation called hypoventilation, which is an immediate effect. And that'll lead to a high PCO2. Right, and that'll be a way for me to compensate of a high CO2 to compensate for my alkalosis. Now, respiratory acidosis. Let's say I have respiratory acidosis. I have a low pH again, and I have a high PCO2 because I'm hypoventilating possibly, or some sort of other issue like COPD or emphysema that's causing me to have a high CO2. I can't get rid of it. As a compensation, I'm going to have a high bicarb effect. So we're going to have this renal compensation. And that's a delayed effect because it takes longer for the kidneys to operate and to compensate. And let's say I have respiratory alkalosis. My respiratory system is leading me to have low CO2. And as a consequence, I have a high pH. But also have, as a compensation mechanism, I'll have low bicarb. I have a low renal bicarb reabsorption to compensate for that alkalosis that I have with my breathing, And that will be a delayed compensation because it's from the kidneys. And so just to keep in mind, so long as you have a compensation mechanism that's present, normatively, it will never outdo the original disorder. So for example, if I have originally a metabolic alkalosis, my compensation will never make it acidotic. And it really typically won't even necessarily make it normal. It will just make it closer to normal. For reference, it will never outdo the original condition. If it did, that means you really have two different conditions going on at the same time. That's a mixed disorder. So just bear that in mind. You will never outdo the compensation will not outdo the original pathology. Now, along with that, if there is a compensation for it, then they will both either be low or both be high. So if you have low CO2, you will also have low bicarb, and vice versa. If you have high bicarb, you will have high CO2, so long as there's compensation for it. The only time when you won't have both of them high is if you have a mixed disorder, or if it's taking time for it to compensate, which is true in the case of the renal system. And anyway, the Henderson-Hasselbalch equation is pH equals 6.1 plus log of bicarb over 0.03 PCO2. The predicted respiratory compensation for a simple metabolic acidosis can be calculated using the Winter's formula. If measured PCO2, which is greater than predicted PCO2, leads to concomitant respiratory acidosis. If measured PCO2 is less than predicted PCO2, then it's a concomitant respiratory alkalosis. So PCO2 equals 1.5 bicarb plus 8 plus or minus 2. It wouldn't be a bad idea to look into some of these formulas like Henderson-Hasselbalch and the Winter's formula, for example. But I would say the biggest thing you need to do for acid-base stuff is just know the basics of that table that I have right there, that we have on this PDF file, on this textbook. Because if you understand how that operates and how compensation works, then you're probably... Oh, that's not good. Well, let me check then if that's running still. Okay, cool. I hope that's fine. Wait a minute. Oh, cool. Awesome. I was going a little bit interesting. Well, hopefully that's all running fine and well. I accidentally saw, I'm not sure if that's accurate, but I saw the original page of the PDF file, so I'll have to go look back at the stream again, I suppose, if I'm getting the pages correct. I'm seeing it correctly now, but for a little while it was a little bit off-putting, so I'll have to check that again. Anyway, so now we're in the final parts of the physiology section of this renal chapter. Again, this is the physiology section. There's another section to it as well. My book right now, my renal section and my physiology section ends on 611. But we don't finish the chapter until, I think, 628, I think is when the final page is. So let me just go back to see that. Yeah, 628 is basically when it ends. So there's a farm section, there's a path section before this. Before the ending, I should say. So here's a chart, acidosis and alkalosis. It says here, check arterial pH. And this is exactly what I'm talking about right here. This is very important. So let's say I check the pH. Oh, the pH is 7.35. That means it's low. That means it's going to be acidotic, right? Acidemia. And so let's say, for example, I have a high PCO2, and also, by the way, you will have a bicarb as a compensation typically. That means you have respiratory acidosis, hypoventilation, airway obstruction, acute lung disease, chronic lung disease, opioid sedatives, weakening of the respiratory muscles. So true. Now let's say, for example, I have a low bicarb and a low PCO2. That means the bicarb is a driving factor. It means I have a metabolic acidosis. Now this is the thing we needed to go check anion gap. You say equals sodium minus chloride minus bicarb. They say that combined basically, but you get the idea. If it's greater than 12 milliequivalents per liter, then you have an anion gap, gold mark, so it could be things like glycols, ethylene glycol, propylene glycol, oxyproline, chronic acetaminophen use, L-lactate, lactic acidosis, D-lactate, exogenous lactic acid, methanol and other alcohols, aspirin, late effect, renal failure, and ketones, diabetic, alcoholic, starvation, that kind of stuff. Now, if it's a normal anion gap, it's between 8 to 12, then it's oh, wow, different acronym. So your acronym is, I don't know if I can say that on YouTube, I'm not sure. You can read it out, it's fine. But my thing says SHARDS. So SHARDS is spironolactone, hyperchloremia / hyperalimentation, Addison's disease, acetazolamide use, renal tubular acidosis, diarrhea, and saline infusion. Okay. So this is a little bit of a different kind of way. If you want to figure out, I have metabolic acidosis, why do I need to know what the anion gap is if I know if I know if I know everything else about it? Well, it helps you kind of eliminate some possibilities for why you have that in the first place. Now, let's say, for example, I have alkalemia. I have a high pH. It's over 7.45, right? What do? I have alkalemia. Well, do you have a high PCO2 and bicarb, or do you have a low PCO2 and bicarb? Let's say, for example, I have a low PCO2, a low bicarb. Then the PCO2 is the driving factor. You have respiratory alkalosis, hyperventilation, anxiety, panic attack, hypoxemia, high altitude, salicylates early, tumor, pulmonary embolism, pregnancy. Very true. Now let's say, for example, I have the opposite, metabolic alkalosis. Right, I have a high PCO2 and I have a high bicarb, and the bicarb is a driving factor in that case, right? In that case, you have metabolic alkalosis. You would check the urine chlorine levels, and then you can go check They say, is it greater than 20 or is it less than 20? It's greater than 20. It's saline resistant. So you might have things like hyperaldosteronism. You might have, is this even on here? No, you guys don't have this, but my book has a little bit of a different setup. So let's say it's saline resistance, greater than 20 milliequivalents of chlorine level. It can be hyperaldosteronism, Bartter syndrome, Gittleman syndrome, current loop thiazide diuretic, that kind of stuff. Now let's say, for example, I actually have a saline responsive type. It is lower than 20 milliequivalents of chlorine per liter. Then it can become vomiting, a recent loop diuretic, loop or thiazide diuretic, or it could be because of antacids. Now, I don't know if you're ever going to see that on an exam, but just something to be aware of, I guess you could say. You do have that cool chart there, though, where it's showing, like, oh, this is the buffer line, and this is the showing the plasma levels versus the pH, and so this is what's going to be respiratory acidosis versus metabolic alkalosis. This is where the metabolic acidosis versus respiratory alkalosis is going to be. I definitely need to learn how to interpret that kind of stuff. I learned about that a few days ago in one of my classes, so I just need to kind of recap on that and just make sure that I have a good understanding of that whole thing. It looks like renal pathology is coming up close for you guys right here. It shows up on the textbook on 562. Mine will be after I finish this page 611 right here. So renal tubular acidosis. A disorder of the renal tubules that leads to normal anion gap, hyperchloremic, metabolic acidosis. So there's different kinds of these renal tubular acidoses, so I'll just read them out and explain them by defect, pH, serum potassium, causes, and associations. So distal renal tubular acidosis, RTA type 1. The inability of the alpha intercalated cells to secrete H1 ions, hydrogen ions, no new bicarb is generated, metabolic acidosis. Their pH is greater than 5.5. Okay, that's not really saying a lot. That's still pretty acidotic, right? Lower serum potassium levels and causes amphotericin B toxicity, analgesic nephropathy, congenital anomalies, obstruction of urinary tract, autoimmune disorders like lupus. So those are the things that can cause it. Things like amphotericin B toxicity, lupus, obstruction of the urinary tract, analgesic nephropathy. These things can cause this kind of condition. And associations with increased risk of calcium phosphate kidney stones due to increase in urine pH and increase in bone turnover related to buffering. Okay. Now the other one is the proximal renal tubular acidosis, RTA type 2. Defect in proximal convoluted tubule, PCT, and bicarbonate. Okay. Bicarb, yeah, reabsorption, leading to an increase in excretion of bicarb in urine. Metabolic acidosis. Urine can be acidified by alpha intercalated cells in collecting duct, but not enough to overcome the bicarb excretion. Where was that? Okay. Yeah. This is going to have a pH less than 5.5. That's pretty serious. When plasma bicarb below reduced reabsorption threshold, or an increase in greater than 5.5 when filtered bicarb exceeds reabsorptive threshold. There'll be a decrease in potassium, serum potassium, and it's going to be associated with or caused by Fanconi syndrome, multiple myeloma, carbonic anhydrase, and carbonic anhydrase inhibitors. Okay, so I think it'd be like acetazolamide would be an example of that. I think an association of RTA type 2 would be an increased risk for hypophosphatemic rickets and Fanconi syndrome. Okay, and let's go to hyperkalemic tubular acidosis, or RTA type 4. Okay, that's going to be a defect related to hypoaldosteronism or aldosterone resistance, hyperkalemia, leading to a decrease in ammonia synthesis in PCT, leading to a decrease in ammonium ion excretion. Now, there's variable levels of pH in the case of this RTA type 4. There will actually be an increase in serum potassium, which is a little bit weird compared to the other ones. Now, it's caused by a decrease in aldosterone production, that is to say, diabetic hyporenism, ACE inhibitors, ARB, NSAIDs, heparin, cyclosporine, adrenal insufficiency, or aldosterone resistance. That is to say, potassium-sparing diuretics, nephropathy due to obstruction, and Bactrim as well. Okay. Your book says renal path. I'm actually going to be finishing up. There's just like a diagram right here showing, these different kinds of transporters at RTA type 1, RTA type 2, and RTA type 4. I really can't make heads or tails of this right now, but I'm going to go switch the page over to the renal pathology section. That's on page 612 of the, I think, 2025 or 2026 textbook. And of course, you have your page right here. I'm going to take a short break and come back. And we'll be going on all the way until renal pharmacology in 625, I guess. And then from there, we'll be doing that for another couple of pages until we finish up the book at 628. So this is like an intermission break kind of thing. If you are watching this after this has been posted, I would just skip forward for a little bit. Okay, I think I might be back for a little for a little while. You know, let me see something. Okay, so let's go back here. Okay, okay. And wow. So this is one thing I've noticed too as well. I always feel to myself, oh wow, I spend so much time reading these textbook chapters. It's not even that long of a chapter. It's only like this many pages, and it's like, I mean, sure, but like, can we just be honest with ourselves? It is actually quite long. You know. Hmm. Like I don't think I need to really mince words with that. It's not necessarily super easy to get through these chapters, and I think always, especially when the physiology chapters, for example, I always want to have like a brief review of it, that kind of thing, just to make sure that I really comprehend what's going on. Because just doing a simple reading of something, and that's true for lectures too. I've never been to a lecture before where you don't know what they're talking about. You go in and you listen to a lecture for for like an hour and a half, an hour, 2 hours, whatever. Two, three, almost 3 hours in some cases. It's not super common, but that does happen. And you're like, I don't even know what they're talking about half the time. It is an unfortunate situation sometimes. And so for me, one of the biggest things is independent study and reviewing it multiple times so that I actually understand what's going on. My big recommendation, of course, is that if you're looking at a topic like the kidneys, I would watch videos on it. I would read stuff about it. I would read textbook chapters, summaries of textbook chapters, multiple different ways to look at the same thing, and whatever works best for you, just to make sure that you have a good understanding of the topic at hand, and including quizzing yourself on it. You could do flashcards, Anki decks, Quizlet, simply just taking a piece of paper out and holding a piece of paper over it and saying, okay, what is the location in which the acetazolamide acts on in the nephron, and you just have to guess, oh, it's this thing, that kind of thing. So anyway, we'll go into the renal pathology section. This section is going to be still relatively long, and I might take breaks here and there with it. My stream has only been going on for, it says here, about an hour and a half. I feel it was a lot longer than that. I felt like it was at least a century, so we'll see how it goes. Renal pathology. Casts in urine. The presence of casts indicate that hematuria, pyuria, is of glomerular or renal tubular origin. Bladder cancer, kidney stones, and lead to hematuria, but no casts. Acute cystitis leads to pyuria, but no casts. All casts contain a matrix composed primarily of TAM horsefall mucoprotein, uromodulin, secreted by renal tubular cells to prevent UTIs. RBC casts. Here we go. RBC casts, glomerulonephritis, hypertensive emergency. This is important too. Now, here's the thing too with this is that, no, I think this is probably correct. Is that you will get questions on the exams, on COMLEX, on step 1. And obviously, if you're in medical school, you'll get it in medical school. They'll say to you, hey, the patient has, white blood cell cast. What is this? Along with the overall vignette. And you just need to know what that is. You have to say, oh, of course, that's going to be, tubulointestinal inflammation, acute pyelonephritis, or transplant rejection, right? You just have to be able to clock it for what it is immediately. RBC cast, glomerulonephritis, malignant hypertension, of course, right? Fatty casts, nephrotic syndrome associated with Maltese cross sign, interesting. Oval fat bodies is another way to describe it. Granular casts, acute tubular necrosis, ATN, can be a muddy brown in appearance for granular casts. Now, in my medical school, we are talking a lot about acute tubular necrosis recently, so there's a lot of talk about granular casts, which are kind of a muddy brown appearance, yeah. Waxy casts, a little bit different. End-stage renal disease or chronic kidney disease. Hyaline casts, nonspecific, can be a normal finding with dehydration, exercise, or diuretic therapy. True. These are just kind of pictures of it right here. You can see RBC cast right there, a white blood cell cast, a granular muddy brown cast, of course, does look muddy brown, and a hyaline cast and a waxy cast, of course. Nomenclature of glomerular disorders. showing type, characteristics, and examples. So focal glomerular disorder, less than 50% of glomeruli are involved, like a focal segmental glomerular sclerosis, so that's FSGS. Important to make note of. You can have a diffuse type, which is greater than 50% of glomeruli are involved, and that'd be something like diffuse proliferative glomerulonephritis. And another thing to make note of when they say something like, I think it's it's membranous. I'm trying to think about the correct term for this stuff, but I'll get into that. Proliferative type. Hypercellular glomeruli, membranoproliferative glomerulonephritis, and you also have a membranous type, which is a thickening of the glomerular basement membrane, leading to an example of that would be membranous nephropathy. I think it is with the membranous types that you have an association of thickening and even an association of, if I'm not mistaken, with these sorts of complex deposits, that kind of thing, immune complexes. Something to be aware of. Now, primary glomerular disease. Primary disease of the kidneys, specifically impacting the glomeruli. Minimal change disease is a good example of that. Secondary glomerular disease. Systemic diseases of disease of another organ system that also impacts the glomeruli, like lupus or diabetic nephropathy. Now, glomerular diseases shows here. You have a different diagram. Okay, here we go. That's fun. Actually, you know what? I like the diagram. It's kind of cool. It has 3 different little circles right there, or you can say ovals, more apt, right? This is not a a class on, I guess, what do you call it? This is a medical school. Fundamentally, knowing the difference between ovals and circles is not really the main concern, but whatever. Glomerular diseases. I have a diagram of nephrotic syndrome, nephritic syndrome, and nephritic nephrotic syndrome, which you have kind of a similar thing going on right here. So there's glomerular capillaries, basement membrane, podocytes, urinary Bowman space, endothelial cells. That's all fun and well. Proteins, RBCs. And so it's showing right here in a nephritic syndrome, you're going to have a lot of RBCs being lost and not very many proteins. But when you have a nephrotic syndrome, you have a lot of proteins being lost and not very many RBCs. But when you have a nephritic nephrotic, sort of like this intermediate type, you have kind of a mix of both being lost. So nephritic syndrome, let's talk about nephritic syndrome. That's the RBC heavy one. Etiology, glomerular inflammation leading to GBM damage, leading to loss of RBCs into the urine, leading to dysmorphic RBCs, hematuria. Clinical presentation, hematuria, RBC cast in urine, decreasing the GFR, causing oliguria, azotemia, and increased renin release. Hypertension, proteinuria, often in the subnephrotic range of less than 3.5 grams per day, but in severe cases may be nephrotic in range. That's an important thing to note. So they like to say there's between, nephritic versus nephrotic is it greater than 3.5? In which case, if it's greater than 3.5, it's nephrotic, but if it's less than 3.5, it's nephritic. Now, examples of nephritic syndrome would be infection-associated glomerulonephritis, Goodpasture syndrome, IgA nephropathy, which is also called Berger disease, Alport syndrome, membranoproliferative glomerulonephritis. Now let's talk about nephrotic syndrome. It's kind of the opposite end of the spectrum. Podocyte damage leading to impaired charge barrier leading to proteinuria, massive proteinuria greater than 3.5 grams a day, with edema, hyperalbuminemia, and that's very important, it's leading to the edema, leading to increase in hepatic lipogenesis, hypercholesterolemia, frothy urine with fatty casts associated with hypercoagulable state, that is to say, renal vein thrombosis due to antithrombin loss in urine, and increased risk of infection, loss of IgGs in urine, and loss of soft tissue compromised by edema. Now, examples of this would be, it may be a primary, that is to say, direct podocyte damage, or secondary podocyte damage from systemic processes like focal segmental glomerular sclerosis, primary or secondary, minimal change disease, primary or secondary, membranous nephropathy, primary or secondary, amyloidosis, which is secondary necessarily, basically, and diabetic glomerular nephropathy, which is secondary. Then we also have, of course, why not the best of both worlds, right? Why not just have something that's nephritic and nephrotic? Something that's intermediate. Nephritic nephrotic syndrome, severe GBM damage leading to a loss of RBCs into the urine, plus impaired charge barrier leading to hematuria and proteinuria. So it has a nephrotic range of proteinuria and a concomitant features of nephritic syndrome. So basically, when somebody says, oh, it's nephritic nephrotic, it really is a nephrotic syndrome with additionally nephritic features. So nephritic nephrotic syndrome examples would include, it can occur with any form of nephritic syndrome, but is most common with diffuse proliferative glomerulonephritis and membranous-proliferative glomerulonephritis. So maybe a better way to phrase it would be this: is a nephritic nephrotic syndrome is like a nephritic syndrome, but it technically qualifies as a nephrotic syndrome because it is greater than 3.5 in terms of protein loss. So it kind of looks like a nephritic syndrome, but it is technically a nephrotic syndrome, but it has both going on at the same time. Oh, that's fun. Nephritic syndrome. So now we're going to go one by one. Infection-related glomerulonephritis. So mechanism, do we have this here? Yeah, we do. Kind of. So infection-related glomerulonephritis. Mechanism, type 3 hypersensitivity reaction with consumptive hypocomplementemia. Children would seen in 2 to 4 weeks after group A strep infection, pharyngitis or skin infection, right? Adults, staphylococcus in addition to causative agent. In a light microscopy, enlarged and hypercellular glomeruli, and that's a little bit farther down. And it says here, immunofluorescence, granular starry sky appearance, lumpy bumpy, due to IgG, IgM, and C3 deposition along GBM and mesangium. Electron microscopy for infection-related glomerulonephritis, subepithelial IC humps. Okay. Now what about IgA nephropathy? That would be Berger disease. It occurs concurrently with respiratory or GI tract infections. IgA is secreted by mucosal linings. Renal pathology of IgA vasculitis. Mesangial proliferation is when you see light microscopy. Now in immunofluorescence, you'll see IgA-based IC deposits in mesangium. True. And in electron microscopy, you'll see mesangial IC deposition. Okay. Now rapidly progressive crescent is the important word, crescentic glomerulonephritis, so RPGN. So poor prognosis, multiple causes, type 2 HSR, I would assume that's referring to the sensitivity reaction, in Goodpasture syndrome, okay. Crescent moon shape, crescents consist of fibrin and plasma proteins, as to say C3b, with glomerular parietal cells, monocytes, and macrophages. Linear immunofluorescence due to antibodies due to GBM and alveolar basement membrane. Goodpasture syndrome, hematuria and hemoptysis. Negative IF, Pachi immune. No IgC3 deposition. Granulomatosis with polyangiitis, PR3, ANCA, and C-ANCA. Eosinophilic granulomatosis with polyangiitis or microscopic polyangiitis, MPO-ANCA. MPO-ANCA, P-ANCA, granular IF, PSGN, or DPGN. And I believe there's some really good videos by, I'd like to say Pathoma, but it might be Boards and Beyond and some of this stuff as well. If you want to know more about these kinds of conditions, I would definitely recommend some of the stuff they've been putting out. Well, they have put out, I should say. It's probably been a while since they actually published that stuff, but that's a good resource for video resources. If you want to say, oh, I want to learn more about, XYZ diseases, I'd recommend Pathoma, or maybe Boards and Beyond. Electron microscopy. Goodpasture syndrome breaks in the glomerular basement membrane, necrosis and crescent formation with no deposits. Pouchy immune, usually no deposits. EM features depend on underlying cause. Now, diffuse proliferative glomerulonephritis, or DPGN, often due to lupus, think wire lupus, DPGN and MPGN, often present as nephritic and nephrotic syndromes concurrently. Wire looping of capillaries. There's a granular immunofluorescence. That's important. Now, granular is going to kind of help you indicate what kind of things are being deposited for reference, right? And then subendothelial, sometimes subepithelial or intramembranous IgG-based ICs, often ICs with C3 deposition. Okay, so subendothelial, sometimes subepithelial or intramembranous IgG-based ICs often with C3 deposition. Okay, and now we're going to go over to Alport syndrome, I think. Here we go. I feel like I have to go review those videos myself just on these conditions because I feel like I or maybe review an outline or something like that on that stuff because it is a lot to take in. I would say. Nephritic syndrome continued, Alport syndrome, type 4 collagen mutation, GBM alterations, mostly X-linked dominant, eye problems, retinopathy, anterior lenticonus, glomerulonephritis, sensorineural hearing loss, can't see, can't pee, can't hear a bee. Okay, they're really stretching with that last one right there. Can't hear a bee. Okay, whatever. Irregular thinning and thickening and splitting of the GBM. The IF will initially be negative. Nonspecific staining usually stays negative. Yeah, that's a good point. Now, the electron microscopy will be basket weave appearance due to the irregular thickening and longitudinal splitting of the GBM. Now, membranoproliferative glomerulonephritis, or MPGN, type 1 and maybe secondary to HBV or HCV infection, type 2 associated with C3 nephritic factor IgG antibody that stabilizes C3 convertase, leading to persistent complement activation, leading to a decrease in C3. Mesangial ingrowth leading to GBM splitting, leading to tram track on H&E in past. That's important, tram track appearance and stains. And that goes back into, by the way, about how that actually presents. The reason why it presents that way is particular to its pathophysiology. How is it developed? That kind of thing. And I think again, I think the Pathoma videos are very good about that. Now, the IF will be granular, of course, right? Because of those antibodies that are hanging around. And you're going to have for electron microscopy a type 1, some endothelial IC deposits, and type 2 will be intramembranous deposits, also called dense deposit disease. True. You can see some pictures right here for A, B. A is going to be I have it right here. The A is the enlarged and hypercellular glomeruli from infection-related glomerulonephritis. B is the granular appearance, lumpy bumpy appearance due to the IgG, IgM, and C3 deposition along with GBM and mesangium right there. And that's going to be immunofluorescence for the infection-related glomerulonephritis. C, you have a different C. That's, oh, well, let me check. Let me check your C. If you can go back to the video yourself. Yeah, so that's RPGN, crescent moon shape. You can see that right there. D is, I don't know why they changed the pictures. The pictures are totally fine. D and E are from the MPGN, and those are part of the description for the. Yeah, they don't even really describe it right here, but whatever. That's for MPGN. There we go. Okay. And I have another diagram looking at F1 arterial, F1 arterial. It's kind of the same idea. It shows right here, there's a mesangial deposition, a subendothelial deposition, an intramembranous deposition, and a subepithelial deposition. And this type 1 and type 2 for MPGN have two different locations for reference. And I think the other one that they're showing is going to be one of these other conditions as well. Well, actually, there's more than one. There's 4 different locations for the depositions. So there's 4 different conditions. Or 3 different conditions with 2 versions for MPGN specifically. And now we're going to go over to nephrotic syndrome. And I'm going to take a little bit of a break before we get into nephrotic syndrome. I'm beginning to question whether or not I should be streaming one of these chapters, just because of how long it takes to get through them, you know? Well, I know they would take a lot longer if I wasn't streaming it, because I'd be, just kind of lackadaisical about it, I suppose. But we'll get back into it. Okay, nephrotic syndrome. There's a mechanism, light microscopy, the IF, and the electron microscopy. So minimal change disease, often primary, idiopathic, triggered by recent infection, immunization, immune stimulus for eyes, rarely secondary to lymphoma, that is to say cytokine-mediated damage, more common in children. For light microscopy is normal glomeruli, lipid may be seen in PT cells, negative immunofluorescence, important to note, and MCD as effacement of podocytes to foot processes, and that's shown in the picture in A, I think. I don't know if you guys are going to have it yet. Well, it's a little bit different, I think. Picture's similar. I don't know. Yeah, it's still there. And there's a description here for nephrotic syndrome in general that I can just read off for you. That's from your book, not in mine. This is nephrotic syndrome, massive proteinuria greater than 3.5 grams a day, with hyperalbuminemia resulting in edema, hyperlipidemia, frothy urine with fatty cast due to podocyte damage disrupting glomerular filtration charge barrier, may be primary, like direct sclerosis of podocytes, or secondary systemic processes, diabetes, secondary damages of podocytes, associated with hypercoagulable state, like thromboembolism, due to antithrombin. I'm sorry, I totally lost it now. AT3 loss in urine and increased risk of infection due to loss of immunoglobulins in urine and soft tissue compromised by edema. So they're saying antithrombin is AT3. Antithrombin 3 is AT3. So is AT2 now actually not angiotensin 2? Is it actually antithrombin 2? I couldn't. No. That's just two different things unrelated. I want to make sure that I'm not confusing things. But they're saying that antithrombin 3 is now going to be called AT3, and apparently we were calling angiotensin 2 AT2, which is very much not totally confusing, right? Anyway. In urine, and increased risk of infection due to loss of immunoglobulins, of course, in urine and soft tissue compromised by edema. Severe nephritic syndrome may be present with nephrotic syndrome features nephritic and nephrotic syndrome if damage to the GBM is severe enough to damage the charge barrier. Okay. So going back to minimal change disease, I should say. That picture is the kind of the same picture we're talking about before. Most common cause of nephrotic syndrome in children, often primary, idiopathic, and may be triggered by recent infection, immunization, immune stimulus. Yeah, as I was talking about before. Anyway, and the effacement of podocyte foot processes. Okay. Now, focal segmental glomerular sclerosis, that's FSGS, can be primary, idiopathic, or secondary, like from HIV infection, sickle cell disease, obesity, or congenital malformations. May progress to CKD, more common in black people. I think Pathoma said it was higher in blacks and Hispanics. I'm not quite sure if it would be because of a genetic thing or because of some sort of like environmental distinction. Sickle cell would seem like it's more of an African thing, but when you say Hispanic, it's kind of like a non-specific thing. Is that you mean Hispanic is because Hispanic is obviously more of a cultural reason for ethnicity as opposed to a racial underlying thing. So, do they mean Hispanics writ large, like just Latin Americans, or do they mean like Hispanics of partial African descent, like Dominicans and Puerto Ricans, or do they mean, mestizo people from like Mexico and Guatemala who have American Indian ancestry? I don't know. I don't know what they meant by that. They say black people here. I don't know. Anyway, light microscopy, segmental sclerosis, and hyalinosis. IF, often negative, but may be positive for nonspecific focal deposits of IgM, C3, and C1. Electron microscopy, effacement of podocyte foot processes. Now, membranous nephropathy, also called membranous glomerular nephritis, can be primary antibodies to phospholipase A2 receptor or secondary to drugs. That is to say, NSAIDs, penicillamine, infections like HBV, HCV, syphilis, Lupus or solid tumors increase risk of thromboembolism, like a DVT or renal vein thrombosis. Now, like microscopy will show for membranous nephropathy, diffuse capillary and GBM thickening. Again, membranous you typically associate with thickening. When they say membranous nephropathy, think about thickening, okay? That's an important thing to be note of. Now, IF will see granular due to immune complex deposition, of course. Again, when you think about granular IF, think immune complex deposition. And when it says electron microscopy, spike and dome appearance of subepithelial deposits. True. Amyloidosis. Kidney most commonly involved organ associated with chronic conditions that predispose to amyloid deposits, that is to say, like AL, amyloid, AA, amyloid, prolonged dialysis. Congo red stain shows apple green bifringence, that's very important to know. Polarized light due to amyloid deposition in the mesangium. AL amyloidosis may be positive for lambda and kappa light chains, and AA amyloidosis may be positive for AA protein. Makes sense. And electron microscopy will show mesangial expansion by amyloid fibrils for the AL amyloidosis, it looks like. Maybe both, I'm not sure. Probably both. Mesangial expansion by amyloid fibrils, okay. And then we have diabetic glomerular nephropathy. And we'll see here, most common cause of end-stage renal disease in the United States, hyperglycemia, non-enzymatic glycation of tissue proteins leading to mesangial expansion, GBM leading to GBM thickening and increased permeability, hyperfiltration, glomerular hypertension, and increase in GFR leading to glomerular hypertrophy and glomerular scarring, glomerular sclerosis, leading to further progression of nephropathy. Look for albuminuria with increased urine albumin to creatinine ratio. ACE inhibitors and ARBs are not renoprotective. So you can use ARBs and ACE inhibitors for renoprotective purposes in this context. Mesangial expansion of GBM thickening, eosinophilic nodular glomerular sclerosis, Kimmel-Steele-Wilson lesions. And that's going to be the picture for D, if I'm not mistaken. I have no idea why they feel the need to modify and change the pictures over time when they're basically the same idea. No, I see no reason. Immunofluorescence, non-specific staining, usually negative. Now, the electron microscopy, prominent thickening of the GBM with expanded mesangium, predominantly due to increased mesangial matrix, segmented podocyte effacement. Okay. Kidney stones. Who doesn't love them, you know? Okay. Kidney stones. We all scream for kidney stones. Kidney stones can lead to severe complications such as hydronephrosis, pyelonephritis, and acute kidney injury, AKI. Obstructed stones present with unilateral flank tenderness, colicky pain radiating to the groin, hematuria. Treat and prevent by encouraging fluid intake, radiolucent stones, I can't see you, cystine, and uric acid. Isn't that fun? It says, I can't see you, cysteine and uric acid. Okay. So what kind of kidney stones can you get? You know, we want to collect them all, right? So let's go see what we can get for calcium. So this is the same table, by the way, that I have in my own book. Calcium, oxalate, hypocitraturia, X-ray findings, radiopaque, hyperdense CT findings. Urine crystals are shaped like envelope or dumbbell. Calcium stones most common, 80%. Calcium oxalate more common than calcium phosphate stones. Can result from ethylene glycol, antifreeze, ingestion, vitamin C overuse. Hypocitraturia, usually associated with decrease in urine pH, malabsorption, Crohn's disease. Treatment would be with thiazide, citrate, and low sodium diet. Interesting. Calcium phosphate would be increase in pH, by the way. Radiopaque, hyperdense, web-shaped prism. Treatment would be with low sodium diet and thiazide. So similar treatment with the both kinds of the calcium stones. Ammonium, magnesium phosphate, struvite stones. That's important. We're going into what exactly that causes that soon. Increase in pH, what precipitates it. Radiopaque, hyperdense, coffin lid sarcophagus. Accounts for 15% of stones caused by infection with urease-positive bugs like Proteus mirabilis. Very important to note that Proteus mirabilis is associated with Staghorn calculi, with struvite stones. So anyway, Proteus mirabilis, Staphylococcus saprophyticus, that's the second leading cause of UTIs, and I think it's very common in women. And Klebsiella, that hydrolyzes urea to ammonia, leading to urine alkalization, commonly formed of Staghorn calculi. Exactly. Treatment would be eradication of underlying infection, surgical removal of stone. It's not fun. Anyway, uric acid causes a decrease in pH. It is radiolucent, visible, rhomboid, or rosettes. And we'll go to the rhomboid. Oh, I want to see what rhomboid looks like. So this is, again, the pictures they just changed the pictures for some reason. I don't know. The pictures are fine and well in my book, as far as they are in your book as well. In fact, I kind of like the old books version of them. They look a little bit nicer, a little bit cooler. It looks like a art project somebody's working on. So A is those calcium-shaped like envelope things you would see on as urine crystals. B is the here's the what is B in your thing? B in this case is a coffin lid. Okay, sure, why not? Okay, that's fine. C, which is B in my book, a little bit different. C in your book is the Staghorn calculi, and we'll get into D soon enough. I don't know if they have the rhomboid rosettes in here. Oh, they do. That's D right here. Rhomboid rosettes is D for you. C for me. And we'll get back into cysteine soon. So cysteine associated with a lower pH. So both uric acid and cysteine are associated with lower pHs, or what precipitated, which is interesting. So cysteine, low pH, faintly radiopaque, moderately radiodense for CT. The urine crystals are hexagonal, as you can see in that picture for E. It is a hereditary autosomal recessive condition in which cysteine reabsorbing PCT transporter loses function, causing cystinuria. Transporter defect also results in poor reabsorption of ornithine, lysine, arginine, and choline. Cysteine is poorly soluble, thus stones form in urine. Usually begins in childhood, can form Staghorn calculi, again like the uric acid ones. Sodium cyanide nitroprusside test positive. 16 stones have 6 sides. Okay. Just know that cysteine is 6-sided, hexagonal, right? It's treatment, low sodium diet, alkalization of urine, chelating agents, tiopronin, penicillamine, if refractory. Okay, wasn't that fun? I'm not sure if hydronephrosis is going to be as fun as kidney stones, but we'll see. And again, we'll wrap up this section, I think, on path is a monster. Path ends on 24. We have 7 pages to go through. Hydronephrosis. Oh, that's a great question. Will I do that? I don't know. We'll have to see. If I actually get caught up too much, then I will stop it early, I guess. I don't know. Maybe I'll have a late lunch, maybe. Hydronephrosis, distension, dilation of renal pelvis and or calyces, which you can see in A right here. It's hard to tell, but it's there. Mostly caused by urinary tract obstruction, that is to say urinary tract stones, severe BPH, congenital obstructions, locally advanced cervical cancer, injury to ureter, and other causes include retroperitoneal fibrosis, vesicoureteral reflux. Dilation occurs proximal to the site of the pathology. Serum creatinine becomes elevated if obstruction is bilateral or if patient has an obstructed solitary kidney. Leads to compression and possibly atrophy of renal cortex and medulla. Urinary. Now, your book is probably organized a little bit differently, but I have urinary incontinence. Mixed incontinence has features of both stress and urinary incontinence. Let me see if I actually have it farther down. I don't know. It doesn't look like it, does it? You have pyelonephritis section. I'm not even going to look for it. I'm just going to go back to my section and just kind of power through for a little bit. Urinary incontinence. Mixed incontinence has features of both stress and urgency incontinence. So there's a stress incontinence, an urgency incontinence, and an overflow incontinence. Let's talk about stress incontinence right now. Mechanism of stress incontinence. Outlet incompetence, urethral hypermobility, or intrinsic sphincter deficiency, leading to a leak with increased intra-abdominal pressure, sneezing, lifting, etc. Positive bladder stress test, directly observed leakage from the urethral opening, coughing up, or Valsalva maneuver. Associations, obesity, pregnancy, vaginal delivery, prostate surgery. Yep, important things to be aware of for incontinence, stress incontinence. Treatment for this, pelvic floor muscle, strengthening Kegel, exercises, weight loss, and pessaries. Urgency incontinence. Urgency incontinence, detrusor overactivity, leak with urge to avoid immediately. That's the mechanism for it. Now, associations, bladder irritation from UTI, stones, tumors, pelvic radiation. How do you treat it? Pelvic floor physical therapy, bladder training, time forwarding, distraction or relaxation techniques, antimuscarinics, that is to say oxybutynin for overactive bladder, or mirabegron, Vivigron. Overflow incontinence, incomplete emptying, detrusor underactivity or outlet obstruction, leak with overfilling, increase in post-void, residual on catheterization or ultrasound. Associations would be urinary retention, polyuria, diabetes, for example, bladder outlet obstructions, that's BPH, and spinal cord injury. Treatment would be catheterization, relief obstruction, as to say alpha blockers for BPH. No, acute cystitis. Again, I don't see it in your book here. Don't worry, I'll be getting to pyelonephritis eventually. But acute cystitis, inflammation of urinary bladder, presents as an suprapubic pain, dysuria, urinary frequency, urgency. Systemic signs would be high fever, chills, are usually absent. So you usually don't have these systemic signs. They just kind of happen independent of that. Risk factors include female sex, short urethra, sexual intercourse, indwelling catheter, diabetes mellitus, impaired bladder emptying. Causes of acute cystitis include E. coli, which is the most common, Staphylococcus saprophyticus, which is the second most common cause, by the second most cause of UTI. So seen in sexually active young women. E. coli is still more common in this group, though. Klebsiella, then Proteus mirabilis. Urine has ammonia scent. Yeah, I would say this. They usually say that Proteus mirabilis has a fishy odor to it, but they say ammonia scent here, so. And Enterococcus species. Labs with positive leukocyte esterase, positive nitrites, indicating presence of Enterobacteriaceae. Sterile pyuria with negative urine cultures. Could suggest urethritis by Neisseria gonorrhea or Chlamydia trachomatis. You just want to be aware of the possibility they might have gonorrhea or something like that. It's just to make sure to rule that out. Treatment would be antibiotics like Bactrim and nitrofurantoin. And when I say Bactrim, I mean trimethoprim sulfamethoxazole. They say TMP SMX, but that's what that is, trimethoprim sulfamethoxazole, also known as Bactrim. Typically, when you're working in the clinic or something like that, they're not going to say, "Nurse, please give me, trimethoprim sulfamethoxazole right now." Like, that's not going to be what you're, whatever. You get the point. They call it Bactrim. Let's see if I can find pyelonephritis. We had that somewhere in here. Oh, we have urinary tract infections right here, acute bacterial cystitis. So this is the same thing I was talking about right now, yeah, the UTIs. So remember, UTIs, urinary tract infection, acute bacterial cystitis, something to be aware of. Right. Now we're back at pyelonephritis. Pyelonephritis. Cool. Acute pyelonephritis. Neutrophils infiltrate renal interstitium. Affects cortex with relative sparing of glomeruli/vessels. Presents with fevers, flank pain, so CVA tenderness. And the way you do that, by the way, how do I know about CVA tenderness? Well, you would do Lloyd's punch. So, for example, I have a patient who's they're sitting down, they're upright. You go behind them, you go to where the kidneys would be on one side or the other. You put your hand on that area, and then you use your other hand as a fist and kind of hit it with the side of your hand. And there's pain or tenderness With that, then that's going to be called a Lloyd's punch test, and that's going to be CVA positive. CVA tenderness is present. That could be indication of either things like acute pyelonephritis. It could be hydronephrosis. It could be some other kind of kidney problem. It's not very specific. It is sensitive, but not specific necessarily. It indicates something could be going wrong. Anyway, back to my point about CVA. Cause for vertebral angle tenderness, nausea/vomiting, chills. Causes include ascending UTI. E. coli is most common. Hematogenous spread to kidneys, presents with white blood cells in urine, plus or minus white blood cell casts. CT would show striated parenchymal enhancement. Risk factors include an indwelling urinary catheter, urinary tract obstruction, vesico-ureteral reflux, diabetes mellitus, pregnancy, progesterone-mediated decrease in ureter tone and compression by gravid uterus. Complications include chronic pyelonephritis, renal papillary necrosis, paranephric abscess with possible posterior spread to adjacent psoas muscle urosepsis. The treatment would be antibiotics. And let's look at chronic pyelonephritis now. The chronic pyelonephritis, the result of recurrent or inadequately treated episodes of acute pyelonephritis, typically requires predisposition to infections such as vesico-ureteral reflux or chronically obstructed kidney stones, coarse, asymmetric corticomedullary scarring, blunted calyces. Tubules can contain eosinophilic cast resembling thyroid tissue, thyroidization of kidney. Wasn't that fun? And they have a picture of that, I think, as well. Do they have that? Yeah, they have it right there. C is thyroidization of kidney. Wasn't that cool? And now I'm going to go into acute kidney injury, which they have some other stuff here. I actually don't have that in my textbook, so I guess they ruled that that was not important enough to keep in the most recent edition. But was super important in the 2017 for some reason. I'm not sure why. So let's see. Let's proceed. Acute kidney injury. Etiology, or let's go into, it says, there's 3 different kinds of AKI for reference. There's pre-renal azotemia, intrinsic renal failure, and post-renal azotemia. So let's talk about that. Let's talk about pre-renal azotemia. So the etiology of pre-renal azotemia, hypovolemia, leading to decreased cardiac output, leading to a decrease in effective circulating volume. For example, heart failure, liver failure. That's why it's pre-renal. It's before the kidney. Something's going wrong before it even gets to the kidneys. Pathophysiology of it, a decrease in renal blood flow leads to a decrease in GFR, leading to an increase in reabsorption of sodium in water and urea. Urine osmolality is going to be above 500. Urine sodium is going to be below 20. And the FeNA is going to be less than 1%. And it's going to serum BUN creatinine is going to be greater than 20. And you have the same table right there as well. Now, what about intrinsic renal failure? Well, intrinsic renal failure is like actually in the kidneys themselves, right? Tubules and interstitium, acute tubular necrosis, ischemia, nephrotoxins, acute interstitial nephritis, glomerulus, acute glomerular nephritis, vascular vasculitis, hypertensive emergency, TTP-HUS. Now, in ATN, patchy necrosis, leading to debris, obstructing tubules, and fluid backflow, decreasing GFR. Now, with urine osmolality, you're going to have a decrease of lower than 350, greater than 40 urine NA, milliequivalents, right, greater than 40. The FeNA is going to be greater than 2%, and the serum BUN creatinine is going to be less than 15. Now, what about post-renal azotemia? Post-renal azotemia, stones, BPH, yeah, neoplasm, congenital anomalies. So what they're saying is basically post-renal stuff that comes after the kidneys, unsurprisingly. And so it's outflow obstructions bilateral. Urine osmolality is going to vary. Urine sodium, FeNA, serum BUN creatinine is all going to vary. It's all going to be variable. Now, in your book, it says something a little bit differently. They say, oh, well, the 3 is going to be below 350, greater than 40, less than 1% mild or greater than 2% severe, and it's going to vary in terms of serum BUN creatinine. What they're basically saying is that post-renal is kind of going to resemble intrinsic renal failure, more or less. Very similar to each other in that sense. But it's probably a little bit more variable in the case of post-renal. Something to keep in mind, I guess. Now, this is interesting because my book doesn't have this section in here, but I might as well read it out because it's in your PDF. Consequences of renal failure: inability to make urine and excrete nitrogenous waste. Consequences are mad hunger, metabolic acidosis, dyslipidemia, particularly triglycerides, hyperkalemia, uremia, clinical syndrome marked by BUN increase, nausea, anorexia, pericarditis, asterixis, encephalopathy, platelet dysfunction, sodium water retention, HF, heart failure, pulmonary edema, hypertension, growth retardation, and developmental delay, erythropoietin failure leading to anemia, and renal osteodystrophy. The two forms of renal failure: acute, ATN, and chronic hypertension, diabetes mellitus, and congenital anomalies. Now, unfortunately, that's not in my book, my version of the book, because that sounds like a pretty good way to help figure out what's going on and what could go wrong in the case of, kidney injuries. I would say that's pretty relevant in my opinion, but, what do I know, right? Okay. Well, that's crazy. So let's continue. Let's go into acute tubular necrosis. Well, no. We have an acute interstitial nephritis before we get into that. Acute interstitial nephritis, also called tubulointerstitial nephritis, acute interstitial renal inflammation, pyuria, classically eosinophils, and azotemia, occurring after administration of drugs that act as haptens, inducing hypersensitivity, diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, quinolones, sulfonamides, less commonly may be secondary to other processes such as systemic infections like mycoplasma, or systemic inflammatory disorders like Sjogren's disease syndrome, lupus, and sarcoidosis. Associated with fever, rash, pyuria, hematuria, and costovertebral angle tenderness, but can be asymptomatic. Remember that the causes of inflammation to your drains: diuretics, rifampin, antibiotics, penicillins, and cephalosporins, proton pump inhibitors, and NSAIDs and sulfa drugs. Okay. And they say, remember the P's. P's, diuretic, pain-free, NSAIDs, penicillins, and cephalosporins, proton pump inhibitors, and rifampin. I'm not going to lie, I think the drains is a little bit better than P's, because I prefer to call diuretics and call them P, because that makes a little more sense, but whatever. They're always workshopping this stuff, Now let's continue. Acute tubular necrosis. Most common cause of intrinsic acute kidney injury in hospitalized patients. Spontaneously resolves in many cases, but can be fatal, especially during initial oliguric phase. Increases in FeNA. Let me make sure that I'm saying that right. Let me look that up, because I know it's in the book, but I just want to... Oh, let me go back to that. Oh, is that how that works? Okay, FeNA. Acronym. Fractional excretion of sodium. Sorry. Yeah. Okay. I just want to confirm. There we go. Okay. So, increase in fractional excretion of sodium. Key findings: granular cast, often muddy brown in appearance, of course, right? 3 stages: inciting event. Then 2, maintenance phase, oliguric, lasts 1 to 3 weeks, risk of hyperkalemia, metabolic acidosis, uremia, also death is possibly fatal, right? The 3, recovery phase, polyuric, BUN, and serum creatinine fall, risk of hypokalemia, and renal wasting of other electrolytes and minerals. Can be caused by ischemic or nephrotoxic injury. Ischemic, secondary to decrease in renal blood flow, that is to say, pre-renal azotemia, results in death of tubular cells and may slough into tubular lumen. B, that's just like a letter showing the picture, by the way. Same thing that you have B on there, I think. PT and thick ascending limb are highly susceptible to injury. The nephrotoxic, secondary to injury resulting from toxic substances like aminoglycosides, radiocontrast agents, lead, cisplatin, ethylene glycol, uric acid, and tumor lysis syndrome. Myoglobinuria, like rhabdomyolysis, hemoglobinuria. PTs are particularly susceptible to injury. Now let's go to diffuse cortical necrosis, which is a thing that I don't know if they mentioned in your book. No, they don't have that here. But diffuse cortical necrosis, acute generalized cortical infarction of both kidneys, likely due to combination of vasospasm and DIC, associated with obstetric catastrophes, that is to say placental abruption and septic shock. Now, renal papillary necrosis. Sloughing of necrotic renal papillae, gross hematuria, may be triggered by recent infection or immune stimulus. Okay. Associated with sickle cell disease or trait, acute pyelonephritis, analgesics, NSAIDs, diabetes mellitus, and it's going to be this sad papa with papillary necrosis. Okay, that's not whatever. Sickle cell disease, acute pyelonephritis, analgesics, diabetes mellitus, sad, papillary necrosis. Okay, and now I have consequences. Now I have consequences of renal failure. The thing we just went over before. So we said mad hunger, metabolic acidosis, dyslipidemia, hypotassium, uremia, sodium water retention for HF and stuff like that, growth retardation, erythropoietin deficiency, anemia, renal osteodystrophy. Okay. 2 forms of renal failure, acute and chronic. Incremental reductions in GFR define the stages of chronic kidney disease. Normal phosphate levels are maintained during early stages of CKD due to the increased levels of fibroblast growth factor 23, FGF23, which promotes renal excretion of phosphate. FGF23 fights phosphate. Uremia syndrome resulting from high urea can be present with pericarditis, encephalopathy, seen with asterixis, anorexia, nausea, pronounced European. Okay, wow, that's so funny. Okay. Renal osteodystrophy. Is that in here? Do we have that in this book? I could have sworn I saw something like that, but... Oh, here we go. Here's that chart that I like that is in the book. Yeah, cool. Is that... I don't see that in my book right now, but... I don't know. I'm going to take a little bit of a break, but we're going to be... I think... Oh, well... We'll be done soon with this section. Okay, sure. Renal osteodystrophy, hypocalcemia, hyperphosphatemia, and failure of vitamin D hydroxylation associated with chronic kidney disease, secondary to hyperparathyroidism, tertiary to hyperparathyroidism, if secondary poorly managed, high serum phosphate can bind with calcium tissue, leading to tissue deposits, leading to a decrease in serum calcium. Decrease in 125 hydroxy dihydroxy D3, whatever, the calcitriol, right? Decrease in interstitial calcium reabsorption or absorption causes subperiosteal thinning of the bones. Well, that's unfortunate. So this is sort of this process of failure of vitamin D3 hydroxylation associated with chronic kidney disease. Okay, I see. Anyway, renal cyst disorder. Renal cyst disorders. Okay, so you have this section right here. Renal cyst disorders. Oh, so fun. This is an important thing, though. We'll get into it soon. Autosomal dominant polycystic kidney disease. Very important. Numerous cysts in cortex and medulla, causing bilateral enlarged kidneys, ultimately destroying kidney parenchyma. Presents with combinations of flank pain, hematuria, hypertension, urinary infection, progressive renal failure in 50% of individuals. Mutation in genes encoding for polycystin protein, PKD1, 85% of cases, chromosome 16, or PKD2, 15% of cases, chromosome 4. It's usually chromosome 16, just for reference, PKD1. Complications include chronic kidney disease and hypertension caused by increase in renin production associated with Berry aneurysms and mitral valve prolapse, benign hepatic cysts, diverticulosis. Now, I want to say something right here, right now. If you have autosomal dominant polycystic kidney disease, if I'm not mistaken, if you're going to die, it's probably from a heart issue. That's the biggest issue, is actually the heart issue. However, Berry aneurysms are a big issue. Not to mention the fact that, your kidneys are completely messed up. Then that's also an issue. But the biggest killer is actually going to be the heart. So they say, hypertension, that kind of thing. Mitral valve prolapse, right? But you can get a Berry aneurysm, that's pretty bad, but it's not the biggest killer. Now, how do you treat it? If hypertension or polyproteinuria develops, treat with ACE inhibitors or ARBs. Yeah, really all you can do is just kind of like manage it, basically. You have it, it sucks, your kidneys look really messed up and weird. If you're like 60 years old and you have this disease or something like that, you've lived a long time, 60 might be a little bit, we have to say, if you're 120 years old, then you're actually old. When you're 60, you're young, right? When you're 70 years old, you're actually like a young person, That's kind of how it goes. If you're like 85 years old, you're basically young, right? Anyway, so if you over time, these kidneys do look more and more messed up, and if you are like 80 years old or whatever, they look really weird and really strange looking, completely alien to what they should look like typically. But they function for longer than you might expect, admittedly. Now, autosomal recessive polycystic kidney disease, recessive this time, mutation in the PKHD1 encoding fibrocystin, cystic dilation of collecting ducts, often presents in infancy and may be seen on prenatal ultrasound. Associated with congenital hepatic fibrosis, significant oliguric renal failure in utero can lead to Potter sequence, concerns beyond neonatal period including systemic hypertension, progressive renal insufficiency, and portal hypertension from congenital hepatic fibrosis. Okay. And you have a little picture right there as well. Does not look fun, Neither of these conditions are particularly fun. They're interesting to look at, but not particularly fun to have them, Autosomal dominant tubulointerstitial kidney disease. Now this one, also called medullary cystic kidney disease, and now you have that one on there, causes tubulointerstitial fibrosis and progressive renal insufficiency with inability to concentrate urine. Medullary cyst, usually not visualized, smaller kidneys on ultrasound, poor prognosis. Well, that's not good. Now, do they have a one for simple versus complex? So simple versus complex renal cysts. Simple cysts are filled with ultrafiltrate anechoic on ultrasound, very common, and account for a majority of all renal masses. Found incidentally and typically asymptomatic. Complex cysts, including those that are septated, enhanced, or have solid components on imaging, require follow-up or removal due to possibility of renal cell carcinoma. Yeah, if you have a solid mass, you think like, oh, what's that? Maybe you have to get it removed. You don't know, right? Because it could be cancerous, but you don't know. You just have to kind of, all right. I guess you could theoretically say, oh, I was just gonna want to not look into it. But if you want to, make sure that it's not cancer, you would have to do a little bit of an investigation, I suppose. And that's the picture of the anechoic and ultrasound, Okay, so they say this is the end of your pathology section, and then we're going into the pharmacology section. Here's the thing. For my book, that's not true. So what I'm going to do is continue with my next section called renovascular disease. So I have a neat little graph that shows the kidney and everything else associated with it. You have ischemia. Ischemia is leading to renin release. Renin release is causing the conversion of angiotensinogen into angiotensin 1. And angiotensin 1 is converted to angiotensin 2, which leads to vasoconstriction, which causes hypertension. It also causes sodium retention, which is going to cause, again, hypertension. And then also it's going to go to the adrenal glands, which is going to release aldosterone, which causes sodium retention, which again, it causes hypertension. So these are all the different methods that angiotensin 2 helps, impacts the body essentially via the kidneys. Or I should say, it comes from the kidneys. Well, angiotensin 2 does not come from the kidneys. It comes from, okay. Now, angiotensin 2, which is a downstream molecule which you need renin in order to create in the first place, which comes from kidneys. I should phrase it like that. How that has so many impacts on the body. Anyway. Renovascular disease. Unilateral or bilateral renal artery stenosis, RAS, leading to a decrease in renal perfusion, leading to an increase in renin and an increase in angiotensin, leading to hypertension. Most common cause is secondary to hypertension in adults. Main cause of RAS. Oh, that's interesting. So most common cause is secondary hypertension in adults. Now, Again, that's secondary hypertension, not primary hypertension. But that is a very important thing. It's something to laugh at, something to be really kind of consider. The main causes of renovascular disease, or main causes of RAS, renal artery stenosis. Atherosclerotic plaques, proximal third of the renal artery, usually in older males and smokers. Fibromuscular dysplasia, distal third, 2/3 of the renal artery or segmental branches, usually young or middle-aged females. For unilateral RAS, affected kidney can atrophy, leading to asymmetric kidney size. Renal venous sampling will show increase in renin in affected kidney, decrease in renin in unaffected kidney. For bilateral RAS, patients can have a sudden rise in creatinine after starting an ACE inhibitor, ARB, or renin inhibitor due to their interference on RAAS-mediated renal perfusion. This can present with severe refractory hypertension, flash pulmonary edema, epigastric flank bruit. Patients with RAS may also have stenosis in other large vessels. Okay, and then we're going to go into a section on renal cell carcinoma. Okay. Renal cell carcinoma, polygonal clear cells, and there's a little diagram for that, filled with accumulated lipids and carbohydrates, often gold yellow, on gross pathology due to increase in lipid content, originates from PCT, invades renal vein, may develop varicocele if left-sided, increase in IVC to the hematogenous spread, leading to metastasis to the lung, bone, and liver. Manifests with flank pain, palpable mass, hematuria, classic triad, as well as anemia, secondary polycythemia, less common, fever, and weight loss, of course, right? Treatment, surgery, ablation for localized disease, immunotherapy like ipilimumab, or targeted therapy for a metastatic disease, rarely curative, resistant to radiation and chemotherapy. Well, isn't that great? Not exactly a fun thing to have. Most common primary renal malignancy. Most common in males 50 to 70 years of age. Increase in incidence with tobacco smoking and obesity associated with paraneoplastic syndromes, that is to say, PTH-RP, ectopic EPO, ACTH, renin, paraneoplastic. Haha. So funny, so interesting. Clear cell, most common subtype associated with gene deletion on chromosome 3, sporadic, or inherited as von Hippel-Lindau syndrome. RCC, 3 letters, chromosome 3, associated with VHL, von Hippel-Lindau syndrome, right? Also 3 letters. Wow. Well, there's a lot of things with 3 letters. I'm not sure if that's particularly a great way of understanding things. Oh, wow, I have a lot of stuff that I still need to get through. I still need to get to page 624. Now, I could have sworn you would think that you would have a section on this right here somewhere talking about renal onosotoma, right? Is it really not mentioned? Yeah, it's just been reorganized. Okay, so I'll go back here. Give me a little bit of a moment. I can assure you, we're in the back end of this stuff now. We only have about 5 pages left, I think, something like that. Okay, renal onosotoma. Benign epithelial cell tumor arising from collecting ducts, renal, red arrow in B, it says. Points to well-circumscribed mass. Yellow arrows point to central scar. Again, you have a different thing, so don't necessarily listen. Just pay attention to the text in this case, I guess. Large eosinophilic cells with abundant mitochondria without perpendicular clearing versus chromophobe renal cell carcinoma. Presents with painless hematuria, flank pain, and abdominal mass. Often resected to exclude malignancy, renal cell carcinoma. Now, nephroblastoma, also called Wilm's tumor. I assume is it Wilm or Wilm? Is the guy German or is he English? I would assume Wilm. I'm not sure. But Wilm's tumor, Most common renal malignancy of early childhood, 2 to 4, contains embryonic glomerular structures, most often presents with large, palpable unilateral flank mass and or hematuria and possible hypertension. Can be associated with loss of function mutations of tumor suppressor genes WT1 or WT2 on chromosomes 11, Wilms tumor. Wow, that's so cool. Okay, I might remember that though. That's the whole point. Just remembering different techniques to remember things. May be a part of several syndromes. Wagner complex, Wilms tumor, aniridia, absence of iris, genitourinary malformations, and range of developmental delays, WT1 deletion. Okay. Or Dennis-Drash syndrome, Wilms tumor, diffuse mesangiosclerosis, early onset nephrotic syndrome, dysgenesis of gonads, male pseudohermaphroditism, and WT1 mutation. Beckwith-Weidman syndrome, Wilms tumor, increase in organ size, organomegaly, tongue enlargement, macroglossia, hemihyperplasia, imprinting defect causing genetic overexpression and associated with WT2 mutation, omphacele. Yeah, okay. They say transitional cell carcinoma, but my thing says urothelial carcinoma of the bladder. So urothelial carcinoma of the bladder, also called transitional cell carcinoma, most common tumor of urinary tract system, can occur in renal calyces, renal pelvis, ureters, and bladder. Can be suggested by painless hematuria, no cast, associated with problems in your pee sac, tobacco smoking, aromatic amines found in dyes, and cyclophosphamide. Okay. And there's a little thing they have right here in your book. This is fibrovascular core, papillary tumor, and dysplastic urothelium. Urothelial carcinoma is a little bit more specific to what's going on. Transitional cell is a little bit more dubious, but yeah, I mean, it's the same idea. And finally, right here, squamous cell carcinoma of the bladder, chronic irritation of urinary bladder leading to squamous metaplasia, causing dysplasia and squamous cell carcinoma. Risk factors include 4 S's, schistosoma hematobium, infection, Middle East, chronic cystitis, smoking, chronic nephrolithiasis, stones, presence with painless hematuria, no casts. Okay, and that concludes the pathology part of the chapter, the renal chapter. Now, I'm not concluding the stream quite yet, even though I typically would eat lunch about this time, basically. So, but I will conclude, because it's only a few more pages, so I might as well just take a short break and then get back into it again. So just give me a minute or so. Okay. I've been going on for 2 hours and 41 minutes. How about that? A lot of content to cover, you know? And again, there's only about, let me see, 1, 2, 3, 4 pages to go through. It's not too crazy. And the pharmacology section is not that bad. Really, the killers are going to be the physiology and the pathology of it. And again, my recommendation to you, if you're listening to this, is definitely go to Pathoma and Boards and Beyond for some of this stuff. They have really good sections on this. And I would recommend reading this book, of course. Very important. Anyway, renal pharmacology. Diuretics, site of action. We just have a little bit of a graph right here with afferent arterioles. We have the proximal convoluted tubule, with the sugars, amino acids, and sodium being reabsorbed. And then we have the descending loop of Henle, and then with the ascending limb of loop of Henle, which is the thick ascending limb. And then we have this distal convoluted tubule, and then we have the collecting duct. Isn't that so fun? And unlike before, we're focusing on maybe like different things like, oh, this is where aldosterone acts, and this is where this acts, that kind of thing. Now we're talking about drugs. We're talking about mannitol, acetazolamide, loop diuretics, thiazides, and potassium-sparing diuretics. Very important stuff. Very important stuff. And so let's get into it. So mannitol, of course, is acting on the descending limb of the loop of Henle. The acetazolamide is acting on that same region, basically, and that's going to be affecting things like carbonic anhydrase. Loop diuretics are going to be impacting the sodium potassium chloride cotransporter. The thiazides are affecting the DCT and messing with the sodium chloride channel. Is it a cotransporter? Whatever. The sodium chloride reabsorption. And the potassium-sparing diuretics are messing with the hydrogen-potassium excretion. And this is a little bit reductionist. This is a little bit minimalist, you could say, as long as we're going on. So let's get into it right now. Diuretics. Oh, that's the entire page. Diuretics effects on electrolyte excretion. So carbonic anhydrase inhibitors. So think about like acetazolamide, for example. It's going to cause an increase in sodium, a big increase in bicarb, a big increase in potassium. It's going to have maybe a neutral or some positive effects on chloride levels. It's going to have no impact on calcium or magnesium. It's going to decrease hydrogen ion levels. Loop diuretics are going to radically increase sodium levels, decrease bicarb, radically increase potassium, radically increase chloride, radically increase calcium, radically increase magnesium, and have some impact increasing the hydrogen ions. Now, thiazides are going to increase sodium, increase bicarb, radically increase potassium, increase chloride, radically decrease calcium, and have maybe increase magnesium, and then increase hydrogen ions. Potassium-sparing diuretics are going to increase sodium. Maybe they don't really have an impact on bicarb. They decrease potassium. They increase chloride. They decrease calcium, or maybe no impact. Magnesium, they might have no impact, or maybe they decrease it, and they will decrease hydrogen ions. So, important thing is that the carbonic anhydrase inhibitors like acetazolamide, loop diuretics, thiazide diuretics, those are all going to go and increase the potassium. Potassium. And then the potassium-sparing diuretics are going to decrease that. And this is talking about excretion, by the way. I should specify that this is all about excretion. So if you're thinking about absorption, that's the opposite effect, obviously. So the potassium-sparing diuretics are going to not excrete the potassium. It's going to decrease that. While everything else is going to encourage the secretion of potassium. So if you have a potassium sparing diuretic, for example, you're going to want to combine them with something else and vice versa, just so you can balance it out a little bit, you know. Blood pH, decrease Acidemia, carbonic anhydrase inhibitors, decrease in bicarb reabsorption. Potassium sparing, aldosterone blockade prevents potassium secretion and hydrogen secretion. Additionally, hyperkalemia leads to potassium entering all cells via the hydrogen-potassium exchanger in exchange for hydrogen ion exiting the cells. Increasing alkalemia. Loop diuretics and thiazides cause alkalemia. So loop diuretics and thiazides cause alkalemia through several mechanisms. Volume contraction leading to an increase in angiotensin II, leading to an increase in sodium hydrogen exchange in the PCT, leading to an increase in bicarb reabsorption, contraction alkalosis. Okay. Potassium loss leads to potassium exiting all cells via the hydrogen-potassium exchanger in exchange for hydrogen entering the cells in low potassium states. Hydrogen rather than potassium is exchanged for sodium in a cortical collecting tubule, alkalosis, and paradoxical aciduria. And now we're going to go one by one. Isn't this fun? Oy vey. Oh my. Mannitol. Mannitol mechanism, osmotic diuretic, increases serum osmolality, leading to a fluid shift from interstitium to intravascular space, increasing the urine flow, decreasing the intracranial intraocular pressure. Clinical use, drug overdose, elevated intracranial intraocular pressures, augmenting diuresis. The adverse effects would be pulmonary edema, dehydration, hypo or hypernatremia, and is contraindicated in anuria and HF. That's very important because you think, oh, well, I need to get rid of all this fluid. What do I do? Do not use it for heart failure. Do not use it for heart failure. Okay. Acetazolamide. Mechanism, carbonic anhydrase inhibitor, causes self-limited NaHCO, sodium bicarb diuresis, and decrease in total body bicarb stores, alkalinizes the urine. Clinical use, glaucoma, metabolic alkalosis, altitude sickness by offsetting respiratory alkalosis. Yeah, because it increases the acid levels by removing it removes the bicarb, so that's good. But contextually, it's good if you're in a situation where you have too much of it. Idiopathic intracranial hypertension, pseudotumor cerebri. Okay. Adverse effects of acetazolamide, proximal renal tubular acidosis, type 2 RTA, paresthesias, ammonia toxicity, sulfur allergy, hypokalemia, promotes calcium phosphate stones insoluble at high pH of urine. Acid acetazolamide causes acidosis. Acetazolamide causes acidosis. Okay, that's cool, man. Whatever you say, man. Loop diuretics, furosemide, bumetanide, and torsemide. Furosemide's a pretty obvious one for loop diuretics. So mechanism, sulfonamide loop diuretics inhibit the co-transport system of sodium potassium chloride of thick ascending limb of loop of Henle. They abolish the hypertonicity of the medulla, preventing concentration of urine association with PGE. Increase in PGE, vasodilatory effect on the afferent arteriole, inhibited by NSAIDs. Increase in calcium excretion, loops lose calcium. Yeah. Clinical use, edematous states, heart failure, cirrhosis, nephrotic syndrome, pulmonary edema, hypertension, hypercalcemia. Here's the adverse effects, though. Ototoxicity, hypokalemia, hypomagnesemia, dehydration, allergy, sulfa, of course, right? Always have to be aware of that. Metabolic alkalosis. And by the way, you'll see if you work at a clinic, if you work at a doctor's office, there's a number of patients who have sulfa allergies, so just be aware of that. Metabolic alkalosis, nephritis, interstitial, and gout. So these are the issues when you take something like furosemide, for example. And they make a acronym out of that. Oh, dang, okay. So just be aware that ototoxicity is a big one, hypokalemia, hypomagnesemia, sulfa. These are big stuff, right? Now, ethacronic acid. Ethacronic acid mechanism, non-sulfonamide inhibitor of the co-transport system, sodium potassium chloride, a thick ascending limb of the loop of Henle. Clinical use, diuresis in patients allergic to sulfa drugs. Adverse effects similar to furosemide but more ototoxic. Okay. Loop earrings hurt your ears. Okay. Yeah, ototoxicity is really important to be aware of in this context. We're almost there. Thiazide diuretics. Hydroxychlorothiazide, chlorothalidone, metallazone. Mechanism of thiazide diuretics inhibits the sodium chloride reabsorption in early DCT, leading to a diluting capacity of nephron, leading to a decrease in calcium excretion. Clinical use of thiazide diuretics, hypertension, heart failure, idiopathic hypercalciuria, nephrogenic diabetes insipidus, osteoporosis, potentiates loop diuretics and refractory volume overload. Okay. A lot of different uses. This is hypergluc. I don't know what that means in this context. We'll read about it. This is adverse effects. Hypokalemic metabolic alkalosis, hyponatremia, hyperglycemia, hyperlipidemia, hyperuricemia, hypercalcemia, sulfa allergy. So that's that. And then potassium sparing diuretics. Potassium sparing diuretics, spironolactone, eplerenone, amiloride, and triamterene. And these do not necessarily have the same mechanism, all the above. They have somewhat different mechanisms, some of them do. So spironolactone and eplerenone are competitive aldosterone receptor antagonists in cortical collecting tubule. And that's why, by the way, spironolactone has other effects on other hormones potentially, which is why you can get, as a man, you can get some issues with like I think it's like gynecomastia and impotency in males. I'm sure there's other effects in women as well, but just to be aware of that. Anyway, triamterene and amiloride block the sodium channels at the same part of the tubule, though. Clinical use: hyperaldosteronism, heart failure, hepatic ascites, spironolactone, nephrogenic DI, amiloride, and anti-androgen spironolactone. True. Adverse effects: hyperkalemia can lead to arrhythmias, endocrine effects of spironolactone, gynecomastia, anti-androgen effects, metabolic acidosis. Yeah, not necessarily the best of things. And we have a few sections left. Now, that's talking about all those things I was talking about. I think no. That's a little bit different from what I was talking about. It's maybe some overlap. I'm not sure. But I have a few things left up my sleeve. It's going to be angiotensin converting enzyme inhibitors, the ACE inhibitors, right here. And that's where we kind of end. Okay, cool. So ACE inhibitors, angiotensin converting enzyme inhibitors, captopril, enalapril, lisinopril, which is the very common one, and ramipril. Mechanism: inhibits the ACE conversion of inhibits ACE, leading to a decrease in angiotensin 2, leading to a decrease in GFR by preventing constriction of efferent arterioles, increasing renin due to loss of negative feedback. Inhibition of ACE also prevents inactivation of bradykinin, a potential vasodilator. That is very true. And so if you have like a coughing, like a dry cough, that can be associated with an ACE inhibitor. And if you have that and you say, oh, I have a lung issue, I don't really want to be taking an ACE inhibitor, what you can do is take an A or B instead. And we'll get into that later. That's an angiotensin 2 receptor blocker, which is what like losartan, candesartan, valsartan, those things are. So we'll get into that later, but that's just the thing to be aware of. That is a side effect of ACE inhibitors. Also, ACE inhibitors, by the way, they'll get into it. Okay. I'm getting ahead of myself. So clinical use: hypertension, heart failure, decrease in mortality, obviously, proteinuria, diabetic nephropathy, prevent unfavorable heart remodeling as a result of chronic hypertension. In chronic kidney disease like diabetic nephropathy, it decreases intraglomerular pressure, slowing GBM thickening. Okay. Adverse effects: it can cause cough, dry, non-productive cough, angioedema, both due to the increase in bradykinin and contraindicated in chlorine esterase inhibitor deficiency. It is a teratogen. Fetal renal malformations, true. Increase in creatinine, leading to a decrease in GFR. Hyperkalemia, hypotension, used with caution in bilateral renal artery stenosis because ACE inhibitors will further decrease GFR, leading to renal failure. So the captopril's catch. I probably will not remember 95% of these little mnemonics or little key phrases that they use to remember things, to be honest with you. Anyway, ARBs, angiotensin II receptor blockers, like losartan, candesartan, valsartan. Mechanism, selectively blocks binding of angiotensin II to the angiotensin receptor. Effects similar to ACE inhibitors, but ARBs do not increase bradykinin. Hypertension, heart failure is used for hypertension, heart failure, or chronic kidney disease, that is to say, diabetic nephropathy with intolerance to ACE inhibitors like cough and angioedema. Adverse effects include hyperkalemia, a decrease in GFR, hypotension, and teratogen. So there's still a teratogenic effect. Aliskiren. So this is aliskiren. This is another thing too. So we were talking about this before. Oh, so you have angiotensinogen, and angiotensinogen is converted via renin into angiotensin 1, and then angiotensin 1 is converted via ACE into angiotensin 2. And so what happens in this case is aliskiren is blocking that earlier step. It's starting at the source. It's saying we don't want to convert angiotensinogen into angiotensin 1. We're going to prevent that. It's called direct renin inhibitor. Blocks conversion of angiotensinogen into angiotensin 1. Aliskiren kills renin. Okay. Clinical uses for hypertension, right? Hyperkalemia. Adverse effects include hyperkalemia, a decrease in GFR, hypotension, angioedema, relatively contraindicated in patients already taking ACE inhibitors or ARBs, and contraindicated in pregnancy. So really, none of these things are good for pregnancy. If you are pregnant, apparently you cannot take ACE inhibitors or ARBs or aliskiren. All of the above, none of those things you should be taking, I guess. Anyway, so let me scroll down. Here's the notes section, so you can go take notes if you wanted to, I guess. And that concludes the renal section of First Aid for the USMLE Step 1 2025, a student-to-student guide. So if you liked this reading, you like this stream, you can smash that like button and hit subscribe and hit that notification bell and leave a comment. No, but seriously, this is a long video. Again, this is mainly for myself personally. But if you stuck around or if you watched the video, hopefully you liked it. My biggest recommendation, though, is to actually read this textbook, or more aptly, in my humble opinion, to learn about renal physiology. I'd watch videos from Pathoma or from Boards and Beyond, more about the physiology of it, and Boards and Beyond. And if you don't like that, if you like a different textbook, you could read if you're in a medical school, they will recommend a PATH textbook to you. And if you're in medical school, they almost certainly recommend Guinan and Hall Physiology to you. So I would recommend those books as well if you want to learn more about the topic at hand. But anyway, thank you for watching. And I don't know, see you next time, I guess. Bye.